Right, good morning. It's 10 o'clock, so welcome to the new People and Health Scrutiny Committee. My name is Jill Taylor. I represent Western Ward in Weymouth and I'm the chair of this committee. This is a new committee which encompasses the scrutiny roles of the Council for Adults and Children's Services and for Health, so this is an exciting time for us. Just for clarification, the policy areas will be taken by our counterpart Overview Committee, and it is clear to both myself and the chair of that committee that we will need to work very closely together to support the Dorset Cabinet, and more importantly, and most importantly, to support the residents of Dorset. Scrutiny is always quoted as being the committee that holds the council to account, which is what we will do. But we should be aiming to do this in a very constructive, positive sort of way and not at all in a confrontational way. If I could ask the people in this Teams meeting to introduce themselves, taking the councillors first. So if I could pass first of all to my Vice Chair, Councillor Rennie. If you could introduce yourself, please, Molly.
Yeah, hello, I'm Molly Rennie. I represent Dorchester East Ward. I'm also the chairman of the Domestic Abuse Forum.
Thank you, Molly. Could I ask Rod Atkins to introduce himself, please?
Yes, I'm Rod Atkins and I represent Ferndown South.
Thank you very much. Councillor Dunseith?
Good morning. My name is Jean Dunseith and I represent Chickrell. Thank you.
Thank you, Jean. Councillor Ezard?
Good morning, Chairman. I'm Councillor Beryl Ezard and I represent Wareham Ward.
Thank you, Beryl. Councillor Gorringe?
Good morning. I'm Councillor Barry Gorringe and I represent St Leonard's and St Ives.
Thank you very much, Barry. Councillor Nick Ireland?
Thank you, Jill. I'm Nick Ireland. I represent Crossways Ward.
Councillor John Orrell?
Councillor Orrell, Melbourne Regis, which most people would understand as Weymouth Town Centre.
Thank you, John. Councillor Penfold?
Everyone, I'm Councillor Mary Penfold and I represent the Upminster Ward.
And lastly, Councillor Pipe, please.
Chairman, it's Helen. I don't think he's actually joined the meeting as yet.
Okay, thank you very much. We've got a number of people here today presenting papers, and if I can have those introduced now, the people. If we could pass to Mr. Tim Goodson, please, who's heading up the team who are representing the Dorset NHS Recovery Plan. If he could introduce himself and also pass to his team for introductions, please.
Hi, morning everyone. I'm Tim Goodson, so I'm the Chief Officer for Dorset Clinical Commissioning Group. And if we go perhaps to Ines first from Dorset County, then Richard, then Sally, and Eugene if he's on the call, then Charlotte.
Sorry, who was first?
Ines, do you want to introduce yourself? You're still muted, Ines. Okay, should we go to Richard Renault first then?
Hello, I'm Richard. I'm the Chief Strategy and Transformation at, well, I'm at Bournemouth at the moment, but soon to be merged on the 1st of October, University Hospitals Dorset, covering Poole, Bournemouth and Christchurch hospitals.
Thanks. I think we've got Sally Sancraft as well. Should go to Sally.
Good morning, everyone. Yes, Sally Sancraft. I'm Director of Primary and Community Care for Dorset CCG.
I can't see whether Eugene is yet on or Charlotte. Either of those two are on.
Bear with me a moment.
I can't see that they are. Should we try Ines again? Ines, are you available?
I just say, Jill, I've arrived.
Okay. Well, we've had introduced Richard and Sally. I wonder when we come to your item, if there are any other people you would like to introduce, then please feel free to do so.
Yeah, that's fine, thanks.
Okay, thank you very much. If I could pass to Teresa Levy now, if you could introduce yourself and your team, if you're bringing people with you. Thank you.
Good morning, Jill. It's just me today, Teresa Levy, Executive Director for Children's Services, Dorset Council.
Thank you very much. And Vivian, could I pass to you?
Can you hear me? Sorry, my mute is constantly stuck. Sorry. Good morning. I'm the Executive Director for Adults and Housing, and with me today I shall pass first to Jill Vicker and then to Tony Meadows. No, Tony, we're doing well. Tony, do you want to come in?
I am actually here, yes. Good morning, everybody. Tony Meadows. I'm the Acting Corporate Director for Adult Social Care Commissioning.
Thank you. Thank you. I understand that we now have Councillor Pipe with us. If I could pass to him to introduce himself.
Thank you, Chairman. Councillor Bill Pipe, representing the good people of the Litchets and Upton. My apologies for being a little late. I was fitting an elderly lady's new hearing aids for her, and it took a little longer than anticipated.
Oh, is she okay?
Yes, it's good.
Good, good. That's brilliant.
It's all part of what we do in Upton.
Absolutely. Thank you very much.
Okay.
And if I can go lastly, but certainly not leastly, to the Democratic team that I have here today, I'm going to pass to Helen to introduce them for me. But I just wanted to make a comment before we did go over, because we've got two additional people with us today who are our new apprentices. I just wanted to welcome them very much from the members, not only of this committee, but from all members. And I can't for the life of me remember what their names is. I know one is Megan and the other, George. I do apologise. George. So welcome to the council, and I hope you really enjoy working for us. So if I could just pass to Helen to introduce them all for us.
Okay. I'm Helen Whitby. I'm taking the notes of the meeting today. Elaine Tibble is acting as producer. Lindsay Watson is acting as her backup. And then, as you say, we've got George there and Megan, I can't remember his surname.
Rochester.
Sorry, Rochester, the new apprentices.
Okay, thank you very much. So welcome everybody to the meeting. I think this meeting, first of all, as I said earlier, it's the first meeting of this committee. And what we wanted to do was something very much around scene setting. We inherited a very long to-do list from other committees that we'll come on to later, but I thought it would be useful as some of the members have done health scrutiny. I have never done health scrutiny. Some of the members have done people and people scrutiny. Some people have done all sorts of scrutiny in their backgrounds on other councils, and some people have done very little scrutiny. So I think what I wanted to do this morning was to have an introduction from the main areas that we will be scrutinising. So when you're looking at that, can you please, and we have these presentations, can you please be looking at things that might interest you, that you think would be useful for us to look at going forward? I would add, we also have a late agenda item that I hope that you've all got on your, you should have had it emailed relatively not long ago. It went out last night, but I've just asked for it to go out again now. and I understand that Tim Goodson has agreed to present that, but we'll come onto that item later. If I can just talk quickly about procedure, what I'm intending to do today is to use the chat bar for the order of running. So I would be really grateful if you use the chat bar for procedural purposes only. And if you would like to speak, if you put RTS into the chat bar, I will call you accordingly. Please don't put anything else into the chat bar, or as I'm sure you're all aware, I will lose the running order off the top. May miss you out. I'm hoping my Vice Chair, Molly, Councillor Rennie, is going to keep an eye on this and make sure I don't miss anybody out. But if I do miss anybody out, please put your name in again and I will make sure I get to you. Right, so first of all, I don't think we have any apologies because I think everyone was there on the roll call. Is that right, Helen?
That's correct, Chairman.
Okay, thank you. The next on our agenda is our terms of reference, which are there for noting. This is a transcript from out of our constitution, which basically sets out the roles of what exactly we are doing. I'm sure you've all read them, and I think as we go forward this morning, we'll be able to use these terms of reference really well. That we're here to scrutinise decisions, we're here to consider papers that are coming through policy and look at those. We're here with a wider remit. We can more or less scrutinise most things, but what I always want to be clear at is what questions do we want answered. Rather than this, we are looking at a paper, what do we want from it? I want to know what questions we're after being answered. I think we're just scrolling down through the terms of reference, which you've now got, we're onto the notes. If I can go on to the next item, which is declarations of interest. Does anybody have any declarations of interest? Could I go to John Orell, please? Sorry, Councillor Orell.
Yeah, thank you, Chair. I'd like to declare an interest in that I am an NHS GP working in Royal Crescent Surgery, Weymouth. I've obtained a dispensation to be able to engage in this committee, but I will withdraw from any topics related to general practice specifically. So, as for example, today's meeting, I will not participate in the GP access section.
Thank you very much, Councillor Orell. Councillor Ireland.
Yes, thank you, Chairman. It's not really relevant to the agenda today, but my wife is employed by Yeovil District Hospital as a matron.
Okay, thank you very much, Councillor Ireland. Right, if there are no more declarations of interest, if we can go on to the first main item onto the agenda, which is the Dorset NHS Recovery. So if for that I can pass over to Mr. Goodson, that would be really good.
Okay, thank you.
Thank you.
I'll just pull up a presentation, which hopefully I can share with people. Can I just check everyone can see that?
Yeah, that's good, Tim. Yeah.
Okay. So what I'm going to run through today is effectively some recovery plans that the NHS is rolling out nationally, just to give a flavour of really the scale of the challenge actually in terms of what is being asked. So overall, the requirement that I've put there at the top is the NHS is being asked, can it return to effectively near normal levels of services that we had pre-COVID? Now that seems a quite straightforward ask, but it's actually a huge undertaking to do that, as clearly we've still got COVID in the system. So all the requirements around protective equipment, the actual sort of social distancing, which we still have to do within the healthcare services, has resulted in the removal of some beds and different flows around the hospitals. And we still need to assess what procedures can safely be done in terms of the risk of actually contracting COVID or spreading COVID versus the benefit of the procedure itself. So that is the ask nationally, and that's what we're going to sort of report back on, just where we've got to on that today. Some of you may have been part of the Joint Scrutiny Committee where we reported around effectively the response to the pandemic, and I think Dorset coped as well as anywhere else would kind of be my response in that. And we're now trying to move on to restoring some of these critical services and making the full use of the capacity wherever we can to do that. I think we need to be clear though that the plans that we've currently got won't actually meet all of the expectations that are being asked by NHS England and NHS Improvement to do that, particularly around the elective care, and you'll see that as we run through. So one of the national asks is, can we lock in any areas of good practice that we've seen, or anything that we would like to continue to do, rather than just going back to effectively the pre-COVID position. And this slide attempts really just to pull out some of those. I mean, it's quite generic, and there's still certainly areas where things are not going 100% right. But overall, we have seen a big shift in terms of being able to use some of the digital technologies and almost doing everything through either a digital approach or telephone triage, rather than keep putting everybody into all the NHS services. And on the whole, they have worked well, and it's been quite a seismic leap forward in actually using some of those sort of technologies across the system. So whilst that's not going to be right for everybody, and it's not going to be right for everything, where we think that does work, we want to continue to do that. I think we've seen a lot of staff working really well together, right across the public sector, and we've probably seen more of that during the COVID period than we had previously to that. It seems to take a really good leap forward, particularly with some of the local authority staff and working across NHS services as well. And we'd like to continue with that. So in terms of what we're actually being asked, what's come out and it's been referred to as the phase 3 plan, mainly because the NHS set out 4 phases effectively to deal with COVID. And when we reported last time, the phase 2 was effectively really dealing with COVID as the main issue. Phase 3 is setting up the services, and phase 4 is really back to business as usual. So currently we're looking at what can we switch back on, and can we start to make inroads into some of the areas where we've now got effectively a backlog to deal with it. So we've pulled out some of the key ones here, and we'll be able to send around the presentation afterwards. I'm not going to go through all these in detail, you can sort of see them there, but it's really looking at some of the existing standards that already existed, and effectively saying, look, can you actually now start to try to move back to some of those targets? So cancer one there at the top, the NHS has effectively a 2-week standard, a 31-day standard, and a 62-day standard. And it's really trying to reduce the patients on that, because some of those treatments have been suspended during that. And we've got a number of patients now which effectively you've got 104 days. So how do we get those patients in, get them through, and sort of proceed with that? And that's going to be a one-on-one conversation really with the patient and the clinician. Similarly for some of the primary care services there and the community care, and you can see what's listed there, so I won't go through it. Some of the immunisations and some of the screening programmes to start to get services up and going again. Other similar ones for mental health, learning disabilities. Again, we know there is going to be a backlog of people that have had mental health issues during this period. And there is a concern, is there suddenly going to be a bit of a bow wave of, sort of people coming forward on that? So kind of be ready for that and to start to reconnect with a lot of people. Urgent emergency care, I mean, it's always an issue going into winter, and you know, we've still got effectively you know, the potential of winter in terms of, you know, slips and trips and falls, that type of thing that we see much more of. The NHS, and you've probably seen this on the news now, starting to undertake the largest flu vaccination programme that it's ever done. There was on the national news again today the first sort of rollout of 111 First, which is trying to use effectively again the telephone triage and use that to book more appointments into the appropriate service rather than people going straight into A&E. So that there are some trials going on with almost booking an A&E appointment or using it to book effectively an appointment with appropriate services. So these sort of targets are all sat within the NHS ask to switch services all back on. There's actually within it quite a detailed breakdown in terms of sort of percentage of last year's activity. So this is a simplified version of it, and generally it's saying, as you can see there, look, can you get to 70% of last year's activity in August, increase it to 80%, 90%, then 100% by October, and there are different versions of that by different sort of specialties in the area. But generally, that is an overview of the ask in terms of can you get everything going back by October to do that. Which, as I said at the start, that is an enormous ask, and you'll see in a minute we're not at that level, and we're not unusual in that. I haven't seen anywhere that can effectively say that they can meet this sort of level at the moment. And as I mentioned there's also the requirement. Let's lock in some of the advances we've actually made with some of the triage process using some of the video conferencing and the teleconferencing. So there's been an ask to actually maintain some of that as well. So where we're currently at, and this is very much a first sort of draft set of plans across the system. So I must sort of emphasise that there's effectively a second cut going to go in and a third cut, and we're actually only now really looking at what are we actually doing in terms of the actual performance. So this is very much our plan sort of looking forward, and our current performance is looking slightly better than the plans, but there is this nervousness around the impact of winter. So we've put in there really, you know, the target for most of this is to get everything back up to 100%, you know, as soon as possible. And you can see on some of the areas there, particularly some of the diagnostics, we think we'll go above that and we'll be able to start to make serious inroads into the backlog of patients that we've got and effectively overperform and clear that down. But for some of the other areas there, some of the outpatient appointments and some of the day case elective procedures, you can see that we don't foresee we'll be able to get all services up running at the same level as last year. And again, as I said previously, this is really due to some of the social distancing measures, some of the PPE, and just the nature of some of the procedures. And we have to factor in as well, you know, there is a fatigue issue here with a number of NHS staff. And if we go into a period where people have to self-isolate again, we are going to struggle to get that. Now, that pattern you've got there, you know, it is very similar to other systems that we've seen. I've not seen any NHS system that's predicting effectively a sea of green where they can get everything back up. So at the moment, you know, the ask is a big one, but we don't want to raise any expectations here, and we're being you know, really quite transparent here in terms of the actual size of the task that is ahead of us here and where we're currently at with it. So in terms of what do we think we can do? We think we can get the inpatient electives to actually meet the target, and that's where we bring people in and they're staying overnight for elective procedure. We think we can do that through increasing what we actually do within the NHS, so putting on extra sessions effectively in the evenings and at weekends. So we think we can do that, and we will continue to outsource some of that procedure, which is effectively the use of the private sector hospitals, which the NHS has effectively done a national contract for to make the maximum use of all of the facilities in the country. So we think we can get the inpatients done. We think we can get the MRI and CT scanning, so that diagnostics up to do that. The rest of the narrative there is really a repeat of that slide. You know, we don't think we can get fully up to speed really on some of the outpatient stuff. and we don't think we can get up to speed on some of the diagnostic areas as well, particularly endoscopy, which is one of the key areas that we are struggling with in Dorset. So if I drill down sort of another level underneath that, orthopaedics is very much a concern for us. You know, we've got a very high elderly population in Dorset, and some of the orthopaedic procedures, which are things like hip replacements, you know, some of these are quite long procedures and use quite a lot of theatre time. So we do have a large backlog in that area. Similarly, ophthalmology as well. We've got quite a large waiting list in ophthalmology, which we had going into effectively the COVID period, and same for orthopaedics. Really, you know, these weren't in the best shape going in terms of the patient numbers. So we've still got that, and the COVID period has really sort of shifted the waiting list along by sort of 4 months, because there was very few elective procedures going on during that period. So whilst there were fewer referrals coming into the NHS, and our total wait actually in terms of numbers of people actually dropped because, you know, people weren't effectively engaging and linking in with the NHS so much, but everyone that was on it has almost moved 4 months along a timeline, which has given us 52-week wait problems, and it's just created quite a large backlog there, because we've lost effectively a third of the year's operating time. Endoscopy, which I mentioned there, we have attracted £3.2 million of new investment to go into endoscopy and MRI for Dorset, so that will go into some of the equipment that we think will allow us to actually get more people through that. Urgent care 111, as I said, that we again 111 is under quite a lot of pressure across the country now. You know, a lot of people are using that service and effectively ringing that, which is putting, you know, an enormous pressure up under that. And we are now seeing an increase with our A&E attendances, which effectively had dropped considerably during the COVID period. You know, they are pretty much now up to the normal levels of activity that we'd expect for this time of year. Mental health, as I previously mentioned as well, there is a national standard in terms of a minimum investment going in each year to mental health services, which is higher than the average investment across the NHS. So it's something that's been prioritised, saying, you know, we want you to put more into that than effectively the standard amount. We've managed to achieve that standard across Dorset for the last couple of years, and we believe we'll still be able to deliver that for this year. There's a series of sort of subsections of that. We are less convinced that we'll be able to hit each of the areas underneath it, and to a certain extent there's an ask in terms of, well, where's our current pressure at the moment due to COVID? We want to invest in the areas that actually need it to get them back on track, and that's a conversation that we're having with NHS England as our regulator on this, and they seem relatively comfortable with that. You know, so adapt your plans to meet your local needs, but in terms of the overall investment, we think we can do that. I've mentioned winter a couple of times there, so usually the NHS does a winter plan each year, just setting out how we're going to go about coping with the increased demand that we see in a number of areas across winter. That's not going to be the case this year. It's all been rolled into effectively this phase 3 plan, where they're very much want to know, you know, what can you do to recover from COVID? What's your plans around winter? And equally, you know, sort of a potential flu outbreak as well. So these things are now beginning to well, they are overlapping. So we're trying to build all those into, you know, one set of numbers, so we know the capacity that we've got in the system to do that. Something which is new that's come in is around a discharge to assess model, so a home first, and that's something we're doing in partnership with the local authorities to try and keep the flow through the hospitals. That the one thing that really sort of brings the NHS to its knees is if we've not got people coming out of the hospital quick enough, it just means all the beds get used and it sort of clogs up. So it's really important to keep the flow around doing that. So we're keen to do that. Within primary care, we've also set up, they're referred to there as hot and cold sort of sites, but it's really saying, well, if you've got somebody with suspected COVID, where would you see those people? Where would you see people without COVID? And we've had that now set up across Dorset. And equally, do we want to use some where there's same day access as well, and sort of urgent cases and effectively routine cases? So a number of the GP practices are working together now through sort of smaller primary care networks that we've got spread across Dorset, and they're using different sites for different purposes. And we expect that to continue through the winter period to do that. I briefly mentioned the flu plans there. As I said, this is a huge undertaking now to increase the number of people that get effectively the flu vaccination. Again, all our GP practices are working really hard on that to really effectively do a mass vaccination of a scale that they've not previously done in that. Some of you may have seen on BBC News last night, Saturday, up in North Dorset, they'd taken over one of the small local airfields there, and it was literally a drive-through flu clinic that people were literally going through, and it was kind of done on that sort of grand scale rather than at an individual practice level. You may have seen somebody actually flew into it as well because it was an airfield, so that gave it a nice sort of twist, I suppose, for the story there. There's also, very importantly at the bottom there, we've got the plans to manage sort of outbreaks, which really is the local authorities and public health have overseen, but clearly the NHS will play a large part in that, in ensuring that we can actually respond to any sort of second wave or any outbreak in any individual area to do that. And we're seeing that at the moment, particularly in the Bournemouth, Christchurch, Poole area, that their numbers are quite high and are now on effectively the national sort of watch list, just in terms of the numbers per 100,000 population. So and we're seeing that elsewhere around the country, and I think again today you've heard of other areas being prepared to go back into a form of lockdown similar to what we saw in Leicester, and restricting some of the more recent areas where it was unlocked around some of the pubs and restaurants and things like that. So just in terms of the timetable and where we're going next, and this is very sort of high level really, we're working really hard with the other providers across NHS in Dorset and with national colleagues, just to keep looking at what can we do, what can we switch on, can we do more, and really get as many services operating at full capacity as we can. So we'll revise our next set of plans around that. Will be 21st of September, and then there's another take around that in October, and clearly they won't stop there. This is something that will effectively be the main priority now for probably at least the sort of the next sort of 6 months as we go through that winter period. So it'll continue to evolve and adapt on that, but it does mean we know the size of the challenge, and we know particularly in terms of what is it we've got to focus on, and what are the hotspots that we've got in Dorset that we need to work through. So that was a very quick sort of work through, because I'm conscious that there's quite a lot in that, and people may have questions on that. In terms of who we've got to respond to some of those questions, unfortunately, I think some of my colleagues can't. They can hear us, but they can't actually sort of speak back. So it's likely to be myself and Richard Renaud, who's from Bournemouth and Poole, and Sally, who does a lot of the primary care stuff, to do that. And Charlotte may be able to. She heads up some of our continuing healthcare. I'm not sure if the others have managed to get back on where they can actually speak yet, but we'll see. So I'll pause there, and happy to hand back to yourself, and we can take questions around this.
Okay, thank you very much. That was a really interesting presentation, and thank you very much for doing it. I've got a question myself before I go to the other councillors who are asking to come in to speak. There's been an awful lot in the news over the last few days about testing and testing regimes. Have you got any information about access within Dorset to testing? Because it's clearly going to have quite an impact on your services if we get into a situation where your staff need testing and there are delays of that testing.
Yeah, so the testing is split into two areas. So We have got testing facilities for NHS sort of frontline staff that effectively we do within the NHS and directly to the labs, and that has continued. It is under pressure, I would say, that just in terms of the number of tests that we can actually do, because that does depend upon the equipment we've got and especially the reagent to actually tell you the result of the test. And those reagents are a consumable that are being deployed around the country on areas of highest need again. So that is tight, and we do actually also send tests off to Bristol, and they come back sort of within 24 hours. So that is working okay, but it is quite fine on the wire of doing that. But that is continuing to happen. Most of the areas concerned you've seen nationally now has been the huge increase in people wanting tests to confirm whether they need to self-isolate or not. So the main site in Dorset is the Creekmore site, and in order to get a test there, you have to go through the national booking system to do that. And again, because there is such pressure on the laboratories that give the results and the reagents around that is being prioritised to those areas with the highest outbreaks. So we are seeing the Dorset site being turned off from a booking point of view. So the site is still there and the people are still there, but you can't actually book onto it as it's been reprioritised around the country. So we've had a lot of inquiries around that, and people not happy about doing that. I mean, the advice remains, if you think you've got COVID, then self-isolate, at home around that, and sort of, protect yourself and your family and others as part of that, and just keep trying the national booking system to do that. That's also the route through to get home tests as well. But you would have seen, on the news that system is under huge pressure, and it needs to increase the amount that it can do. It's nationally run, so it's not something we have direct control of within Dorset, but we are very cited on the problems that is giving, and that will impact on people's ability to return to work, and at some point, the more people that self-isolate, that will start impacting on frontline workers, because somebody else in the house will be unsure and effectively will therefore be self-isolating, and that will affect the NHS, care home, social care, and everything.
Okay, thank you. That's going to be really challenging. If I can go over to Councillor Pipe, please.
Thanks, Chairman. Morning, Tim.
Morning.
Firstly, I'd just like to say well done on what you've done so far. My phone is ringing, which I'm not going to answer. There you go. Beg your pardon. Well done for what you've done so far, and working with the team and all the rest of it. And my question is, the staff are now working together in teams, as you've already said, resulting in different and more flexible roles. Are these different and more flexible roles likely to continue post-COVID? And do they have the blessing of the unions at this stage? Or are we likely to see increased wage salary demands as a result of the greater flexibility? And that's another phone ringing.
Let me perhaps bring Richard Renault in, and he can give you the take on that from what they're saying within the hospitals in terms of the different teams. And then perhaps we can go to Sally Sancraft, and she can give you the view from sort of primary care and how the GPs are working together in different teams. So I'll hand over to Richard.
Thank you. Yes, thank you for that, and the comment about the team working, because it has been fantastic, and obviously staff have been brilliant in flexing. So within the NHS, we've seen a lot of staff redeployed, say for instance nursing staff, into critical care or emergency department, and some of the other areas where they've traditionally worked, such as outpatients and other areas that have been the lower priority routine work, that has been managed, I think, very well across Dorset and widely in the NHS, partly because, of course, it's been a national pandemic, and each individual, that training has been put in place to support those. Many of those staff have moved back to their normal areas, because it was temporary. If we see a second spike, then we might obviously need to move those staff back to priority areas. That's been done in conjunction, obviously, with the staff, and we do keep the unions involved and informed, and obviously they're aware of that, and Royal College Nursing and other unions. The key bit about how long will this go on for is obviously more difficult to answer. So at this stage, we're not permanently making those changes, so we are asking staff to continue to be flexible as we go into winter. I think if we look at permanent changes, then obviously there's a recruitment and a sort of more formal process we'd be going through. But certainly for the next 6 months, I think we're going to keep that flexibility. So whilst Tim's talked a lot about the recovery and getting back to normal elective services, and obviously the backlog that's built up and clearing those down, all the while we've got one eye on the need to switch back to more of an emergency footing. So I don't know whether that's answered your question in sufficient detail, but effectively we've got those processes to engage staff and unions about those changes.
Yeah, essentially, do the unions, are they okay with this, the new flexible working? I can't speak to hear. I don't want there to be any labour upsets, if you know what I mean, because of the way that we're now redeploying the staff in their new, changed and more efficient roles. Yeah. Because if it works and it's more efficient, it would seem natural then that we adopt that practice as normal. I just want the assurance that the unions aren't opposed to that at this stage.
Well, at this stage, and that's the I suppose the point I'd make is, if it's a permanent change in a way a service is delivered, yeah, then there's a bit of a sort of longer term process we'd go through. Yeah, okay. I can't speak for the unions, but certainly within University Hospitals Dorset, so Bournemouth and Poole and Christchurch, we've had really good relations with that, and I think the national issues are very much reflected locally around access to PPE, access to appropriate training, access to sport and welfare. Those are the main issues that unions, we'd agree with, are the ones we've focused on. I think there's actually been less concern about that need to move to where the highest need is. And different ways of working to best achieve that. I think that's been less of a concern, but obviously if they become now a permanent way of working, then we would need to go through sort of more formal consultation.
Yeah, okay, that's fine, great. Okay. Thank you.
Should we go to Sally and just get a view from primary care?
Yeah, that'd be good, Tim. Yeah.
Thank you. Good morning. Members will probably be aware that for some time now we've been encouraging practices to work together, originally through localities and now through our primary care networks, to really help with resilience of general practice to maintain and improve access, and we've been doing that for some while. So that put us in Dorset in a very good footing to be able to move forward very quickly to respond to COVID in that mutual aid approach in terms of practice supporting each other, and that of course included flexibility of deployment of workforce as well. Some of our networks over time have developed more formal partnerships through their business arrangements. Other networks are made up of individual practices still, but what we have seen, and we'll touch on this a bit more when we come to the GP access paper, but we have really seen a very goodwill, we're in it together approach from all of our practices, and obviously including the workforce within that. So we are very grateful to our general practice workforce in the way that they've responded, recognising the difficult times for local residents, but also the staff operating within that. So the principles that Richard described apply similarly to primary care, even though that the setup of general practice is quite different than a large foundation trust, but the principles similarly apply.
Oh, thank you, Sally. That's very, very helpful. I'm more than satisfied, Chairman. Thank you very much.
Okay, thank you. Could I ask Councillor Ireland to come in, please? I think he had a question.
Chairman, I think John was before me.
No, I'd like to take you next, please.
Okay, that's fine. Okay. I was just a question for Tim. One of his presentation slides concerned mental health, and you mentioned suicide prevention. I'm sure you're aware there was a Dorset suicide prevention steering group. Which has been operating for probably 2 years, I guess now, which I was a member, and We last met back in February, I think it was 17th of February. And I just wondered if he had any update on when it's likely to resume. Suzanne Green was leading it, I believe.
I don't personally. I don't know whether Eugene's been able to recontact himself to come on and speak. I assume not, as he's not appeared there. I know he's listening in. Sally, are you closer to that in terms of being able to give a date on that? Because Sally heads up the mental health service on the CCG.
Yeah, I can't give you an exact date, but I can find that out for you if that's helpful and come through to Helen to give you the exact date. But what I would probably reiterate is that although the steering group itself might have been paused through COVID, the work around suicide prevention certainly hasn't. And you can imagine that we're all quite concerned about the impact of COVID on people's emotional health and well-being, and we are working very closely with partners about how we develop our capacity and response to recognising people in mental health crisis to be able to respond early. And so that work absolutely hasn't stopped, even though the formal steering group was paused. But I'll find out the exact date from you and let Helen know if that's okay, so it can be passed on to you.
Thank you.
If I go next to Councillor Rennie.
Yes, could I ask about 111 first, please? I think that this sounds a brilliant idea, and that would be such a great way to manage numbers and where everybody's going. Is there some extra funding for more staff for this? You said you were up to your staff complement now, so that's good. But if there's even more calls, will people be waiting even longer and then end up putting the phone down and going to A&E anyway? I just really wanted a bit of an outline around what will happen and how it will be funded.
Yeah, so at the moment the service has been struggling just with the volume of calls that have been sort of coming through it. So we are nervous about pushing even more people there. But what we have done is we have now effectively recruited up to effectively all the vacancies that were in that within that service, but it does take quite a long time to actually induct those people and train them through the actual process and how effectively the service works. So that there is a delay before we can actually put people straight on the phones to do that. In terms of the 111 first, there is national funding being allocated to that. My understanding, which is slightly from memory, I think there's 40 million going to that nationally. So we're about, Dorset as a pan Dorset is roughly 1%. So we're around sort of 400,000 of that would come to Dorset. I think we do need to look at effectively the impact of the last sort of few months and the extent to which people have got used to more telephone triage and video consultation. So I think we could roll that out further, and it already links in with some of our MIU units and our A&E departments and some of the sort of the urgent treatment centres. So if you ring that, they can already book you into those types of services. Yeah. But I think that the big question is, what will the normal demand be on that to make sure there's enough people in there so it can actually cope with that level. And up until now, we've probably been a bit behind on that sort of curve really, which meant people have effectively hung up and probably tried other areas, or they keep ringing back, and that skews your number because you get people. It looks like more people are ringing than they are. It's the same ones, just keep on ringing to do that. I don't know if Richard wants to add to that in terms of just the link with the emergency departments down at the A&Es and how that sort of works.
Yes, I think you're right about the public have accepted much more of a shift to phone-based consultation for outpatients and phoning ahead. So, as Councillor Rennie says, that will help. And also at the moment, because of crowding and social distancing, we are often asking patients to wait in their car and then come back into the A&E department. So it's far better all round to have that 111 first. But it will take a while for the public to get used to that, and also to rebuild that confidence around the time it takes to get through. But at the moment, it would be fair to say that the waits in ED are quite long because of social distancing, because of the PPE, because of the testing. So we are seeing regularly 4-hour waits, more than 4-hour waits for A&E. But I can say from personal experience, first used the NHS in 20 years, I rang 111 and they very eloquently got a system and booked you into a UTC appointment where it's needed. So Dorset is well positioned in having that integrated approach, and I know unfortunately Dorset Healthcare aren't on here, but as the provider of that service, we're really keen to see that as a partner, to see that continue to develop, because it's definitely the way forward.
Thank you, because that's just what I was thinking. I've had such good reports of 111 and the triaging work that is being done as well, and all round, and I think there are so many good things that we can learn from what's happened and the way people have, as other members have said already beforehand and other speakers, this coming together of different surgeries, different working practices. I think it's amazing how everybody's just jumped up and done it. It's good. I'm looking forward to this, to see how this 111 service actually rolls out further. Good, thank you.
Thank you, Councillor Rennie, and thank you for your answers. If I can go next to Councillor Penfold, please.
Thank you, Chairman. Could I ask a question regarding mental health, as I'm one of the champions for the council? Could you update us, please, on improving the access? Because I've been involved with this for some time and it's always an improving access problem. I just wonder if we've got any plans to do this for patients.
Okay, can I'll bring Sally in again on this, and just before she comes in, I mean part of the reason for the mental health investment standard is this very point that mental health has not really had I would say the fair share of the extra money that's been going into the NHS. So nationally they created this standard, so like you must invest. If the NHS gets say a 4% growth for a year, you have to put over that into your NHS mental health services. So we're somewhere around 6%, I think, for this year in terms of new monies going into those services to ensure that it is protected and it's invested in, and it starts to catch up in terms of some of the financial position around that. So everybody actually in the NHS supports doing that. I think it's been an area that's not really had the levels of funding that it should have done over recent years, and this is sort of trying to reset that. But let me bring Sally Sancroft back in to see if she wants to build on that.
Thank you. Yes, I will. Yes, passionate as you are around the improvements that we need to see in mental health services. I'm really pleased about the national and then our local commitment to invest in mental health services, and we've been working with partners very intensively across a whole spectrum of mental health services to make that improvement. So I'll just give you a couple of examples of those. So for one end of the scale, when we've got people in crisis, then we are continuing to grow the psychiatric liaison support within the front doors of the hospitals to be able to make sure that if somebody does end up in our hospital trusts, that there is the right response to those people quickly to get them to the right place at the right time to support them through their mental health crisis. Similarly, as you know, we've done a lot of work around introducing the front rooms and the retreats as part of our acute mental health pathway. And obviously through COVID that was quite difficult, but those services are gradually being stood back up again and taking social distancing rules into place and adapting to that as we need to. So that's sort of around the adults and crisis. Similarly for children and young people, a real concern about the growing needs of children and young people about their emotional health and well-being. So obviously Dorset Healthcare are our main specialist mental health provider, and they have been really working very hard to look at how we can improve access to the specialist mental health services for children. And they this month are launching a gateway service which will really we believe, start to improve the timeliness of access to specialist mental health services. That will be a phased introduction as we learn as we go along in terms of the impact that that's having. But certainly in other areas where they've introduced that, such as Portsmouth and Warrington, that's had a really positive impact on the experience of those children, young people and families, and improved access and timeliness of response. So we see that as a really positive step forward. Similarly, we're working with NHS England about crisis support services for children and young people in their own homes as well. And as you know, within our wider Dorset patch, the BCP as well, we've got the specialist inpatient unit for children called Pebble Lodge. And in a way, to have that on our doorstep, if children are in crisis to need an inpatient is very good, because some young people are having to travel some distance. And then on the other end of the spectrum, we're doing a lot of work, and we call it the Thrive model for children and young people, looking at how we can have early intervention and support to help people's emotional health and well-being. And a lot of that work is connecting in with schools, and we were lucky to be successful with some national bids to introduce mental health workers in schools. And we're going to have 5 sites of groups of schools that will be we're engaging with by January, and we look to roll that out and learn from that across the whole of the county. So again, a really positive step forward, as well as the work that we do with the community and voluntary sector around the early intervention and support. Just a couple of our other areas are steps to wellbeing, so recognising particularly through COVID and the impact of things such as unemployment, the impact on anxiety and depression. We've got a big programme of work about how we're introducing primary mental health workers into our multidisciplinary teams at a primary care network level to enhance the early offer to people with lower level mental health needs. And then finally, you probably know that we made a significant investment commitment following doing a public consultation around dementia to improve our support offer for people with dementia. And we are beginning to mobilise that now. So we will introduce in the new financial year the availability of dementia coordinators that again will work with multidisciplinary teams to support people with dementia and their families and carers. And also improving the diagnostic capacity for people who need to go through that pathway. So just a few examples of different patient groups that fit within our mental health services and the improvements that we're making.
Could I just come back, Chairman?
Yes, please do.
Thank you. I'd just like to say that's really positive news, and a huge thank you for all the tremendous amount of work that you do. Really appreciated. Thank you.
Thank you, Karen.
Thanks. It probably is worth saying that we actually benchmark really well on mental health access compared to the rest of the country, apart really from some of the children's services. So that's why the slide I put up around the mental health investment, it is skewing towards children and young people, some of the access services there. I mean, that's not to say that everything else is great, but actually on a benchmark position, we do well compared to other areas.
Thank you. Good.
Thank you very much. If I can go to Councillor Pipe again now, he's asked to come back. Thank you.
You mentioned the flu jabs and the way that individual practices have set up the method in which they want to see these administered, if you like. The drive-through method is a good method, but some of the locations that I know of that are going to be used for this, you know, aren't quite suitable in the sense that it's one road. I'm talking about a school situation now, where you drive through the school, you get your inoculation and you drive on. But there are better sites locally. Now, do the individual practices have the independence to choose where they administer the flu jabs, or are they laid down by the CCG or like a group of practices, or how will that work, Tim?
To my understanding, and again, Sally may wish to add to this, it's really down for the individual practices and networks to decide how do they think it's the best way to do it. So I know some are bringing just loads into the practice. Others are taking some of the community sites to get people through there. It's probably worth saying that they've not really done this sort of scale thing before, so it is a bit of a case of test it and see, and probably learn from that. So I'm sure we won't get all of them right in that respect. But I think that they're trying to work with their local communities in terms of what is a good site in their area, because obviously the GPs are all based at the heart of their community, so they would have given it their sort of thought on where to do it. Did you want to add to that, Sally?
Yeah, just to say there's no dictate from the CCG about this. It is about using the local facilities that they've got and being quite innovative, I suppose, where we can. What I would encourage and say that if you've got any ideas around sites in which you think would be helpful for the primary care networks to know about and the practices, we're more than happy to help facilitate that connection. We've got a primary care team member who's doing a lot of work on flu, working with the network, so we can feed that in, and we would welcome any offers of support in terms of locations.
Yeah, that's good, because my three practices, the ones that I cover, i.e. Hamworthy, Creekmore, I know they're all BCP, but that's part of the perks of where I live. So it's Hamworthy, Creekmore and Upton practices. They are talking locally with, for instance, Upton Together, and we have offered alternative sites to the one that they've actually currently chosen, and they're going to meet and talk about that today. Now, this is likely to be a dry run for the COVID vaccination when that appears. Is that likely to be the case, Tim? So we actually need to get this pretty much right first time round?
I'm not so sure on that, actually. I think the mass vaccination is likely to be much bigger centres, particularly in the the Bournemouth, Poole, Christchurch area. So I think you're talking a far bigger scale, that somewhere that can do 2,500 people a day every single day, and I think it will be a similar version, but not to that scale, in more of the Dorset Council areas. I'm not sure it will be run out through the GP practices in the same way, okay. just because of the logistics of getting a vaccination. We can't get that trying to do that to 80 practices, because we know some of the vaccinations require they're effectively frozen. So you've got to get them there. You've got to have the right stories to do all that at scale. So I think that's more likely to be like the COVID testing, where you've got big central sites and people go to that, and they'll be dotted around sort of Dorset and on our fringes. But that's all very much still in the air and is being run sort of nationally and regionally. But I think it'll be that type of model just to get through the numbers. I mean, it's effectively the population, isn't it? So it's everybody.
Yeah.
And the benefits of that is it doesn't pull on the GP workforce, because the flu vaccination programme will go on for some months. So, the benefits are in that other model. It won't be pulling on the GP workforce in the same way.
Okay. Thank you both. I shall encourage my three practices to listen more locally. Thank you.
Can I just ask Sally, you've got an RTS in the chat bar. Did you want to come back on anything?
Thank you. No, that was in an earlier one to do with the suicide.
Okay, thank you very much.
Done. Thank you.
Could I go over to Councillor Orell, please? That's a question.
Thank you, Chair. So I'm coming at the end. Unfortunately, that means I've been accumulating questions. I started with one, now I have three. But there we go. So first, may I ask about the mental health access for children? Initially, to compliment the CCG for improving the access for adults. That really has improved a lot in the last few years, so thank you for that. As you rightly acknowledge, it's not so easy for children. And I wonder if some of the improved access efforts are actually being achieved by rejecting referrals, which is a rather perverse way of doing things. It may improve a dashboard people may be seen in a shorter time, but this is the way that some of it's being done. For example, the pathway from GPs to Dorset Hospital for ADHD diagnosis has been closed, has to go through schools. Schools have a disincentive to let people through that pathway, because if they get onto a care plan, the school then has to pay for it. So that pathway has been restricted. Similarly, referrals to CAMS, quite a complicated referral form now with many pages and often rejected. So may I propose another metric for the CCG to help providers genuinely improve access, that they count rejected referrals and that we can see if there's any games being played to improve access times. So that's the first one. Shall I stop there?
Should we pause at that one? I don't know whether Sally is close enough to that service to comment, but if not, I mean, we did have. I know Eugene's listening in because he's been texting me some comments on the mental health service. But if not, we could perhaps ask them for just a briefing note on as a response to those questions, because I think we really want Dorset Healthcare to respond directly to those. Unless you want to add to that, Sally.
I'm happy to make the link to my earlier reference, one in recognising Councillor Orrell's concern around referrals being bounced back from CAMS, from GP referrals. That's been a theme of concern for some time. And so the gateway service that I referenced earlier, in terms of a development around brief intervention, triage and support for referrals into CAMS, we really do see that will be a major step forward in terms of responsiveness and getting those children to the right place first time and not having bounce back of referrals. And that will be rolled out over the next few months. As I mentioned, it's a phased rollout. So the other areas where they've introduced that has improved experience significantly for young people. So we will be evaluating that. And as part of that, we can evaluate if any referrals are being pushed back, because one of the key aims of that is no referrals are pushed back. The child is made sure to get the right service first time. The other reference you were making in terms of the behaviour assessment and behaviour pathway for those young people that have got going through the diagnostic pathway for autism. Autism and those young people with autism is a real area of priority for us, because we're seeing increasing numbers of young people that are experiencing challenging behaviour and the impact that has on their families and communities. So we're doing a big piece of work at the moment with partners around reviewing those services, and that includes reviewing the current assessment and behaviour pathway that you were referring to. There's a historic issue about how we understand the data flows through those services because of the way data is captured, which we're working with the trusts on, but we're also working with the children and families to get their feedback and experience. We've already done a survey of those young people, working very closely with the Parent and Carers Forum that advocate for young people with autism. So I understand your concerns, but can give you reassurance, but we understand that and we're doing something about it with an aim to improve that pathway.
Great, thank you for the acknowledgement of the problem and the pledges of action. Might I suggest, the Chair, for our area of future work, we might like to come back to this in, say, 6 or 9 months to get some reassurance that these actions have taken place and the metrics have improved. Thank you. Second one was about gastroscopies. I note it was green on the performance chart, which may be the case for the whole of Dorset. There's a particular problem in West Dorset in that the pathway has been closed for routine and urgent GP referrals, and only 2-week waits are progressing, and all those ones that were routine and urgent were returned to primary care unsorted. So that's it's good. The colonoscopies, the ones that are shown as are progressing, but there's a particular problem in West Dorset with gastroscopies and access being restricted. So might I be reassured that some of this 3.2 million is going to come to West Dorset to fix this problem?
So I don't know whether Nhs has yet been able to come on to speak. I know she is listening, but she can certainly. Oh, she's popped up there. There she is. So I can say, so of the 3.2 million, the lion's share of that is actually going to Dorset County Hospital. But let me bring in Nhs in on that.
Yes, good morning. Ines Robos, I'm Chief Operating Officer, Dorset County. Hopefully you can hear me. So yes, the lion's share is for Dorset County. However, a big part of it as well is MRI, because it's not just endoscopy, adopt and adapt. It is both imaging and endoscopy. However, the significant item in there was increasing ventilation. So sorting out the ventilation in endoscopy rooms, and that will allow us significantly increase the throughput. There's some additional scopes as well, which will increase productivity. And in the meantime, we are insourcing from another company. So we are running weekend lists already, even before we do those estates works.
Good. Okay, well, I hope endoscopy will improve alongside the MRI, which is also equally welcome.
Yeah, MRI we have sorted in Dorset County, both MRI and CT we are booking in target now. And endoscopy having gone through with our team, we expect 100% achievement in a couple of months for Dorset County.
Okay, well, the achievement, as I was saying, is only by restricting it to 2-week waits. So what we'd like to happen is...
No, for 6 week, for the normal diagnostics, for a 6-week wait for diagnostics, that's a routine, that's not the 2-week waits. Okay. 2-week waits is sorted for us already.
Good, okay, well, I'll start sending forward some routine and urgents again, because some of those will have cancer, and at the moment, the last few months, we've been not able to progress them. So that's great news. Final question then is one of my favourite topics is step down capacity in the face of a pandemic. We've had a very Dorset has moved to become a very efficient system. It's trimmed away all the excess fat, and it's been very which is great when things are going well, but when things come under strain, there isn't the spare capacity to provide resilience, in my opinion. Tim, just to prove I was listening, you said the thing that brings the NHS to its knees is not getting patients out quick enough. I completely agree with that. And one of the ways of getting people out quicker is to have somewhere for them to step down to. In the first wave of the pandemic, some of that step down nationally was done by moving people into care homes, and that then spread the coronavirus into care homes. So that's not the right route, and that's been closed. We also tried the route of using hotels. That's not right either. We've 700,000 for 3 patients. The reason for that is when people are medically fit for discharge, they're not necessarily nursing fit for discharge or socially fit for discharge. So they still need a bit of looking after, more than can be provided by Great Western hotels. Which brings us back to the idea of community hospital beds and whether we've cut too many in the good times so we don't have enough in the bad times. Particular illustration of that is whether there are been too many cuts of community hospital beds in the east, so that there may now be patients moving out of Bournemouth Hospital into community hospital beds in West Dorset, and it'd be nice to come back with some metrics on that for future meetings. So have we cut too much? Do we need more step down, ready for the second wave?
So there's a number of points in there. I think we'd have to put a bit of a question mark over was getting people out of the NHS, did that really put COVID into the care homes? There's speculation around that, but I'm not quite so sure that people within the acute trust had the COVID, and it could have got into care homes via staff and all sorts of areas. So I think that's one nationally that's going to be sort of looked at in terms of that sort of plan and response. So let's just not jump to that conclusion. I think at this point, I think one of the things we were aware of was an awful lot of people in the east were ending up effectively in the community hospitals in the west. So whilst they were under pressure, it wasn't necessarily from people in the west. It was actually from people in the east of the county coming across. So start of the proposals were to increase effectively the community beds and facilities in the east to keep people in the east, predominantly in the east. And the plans that we've got are actually to increase the number of community beds that are available, but not necessarily all in community hospitals. So the actual proposals around that included some of the care home beds and increasing those sorts of facilities. So I think we need to be careful saying that, are we actually reducing that? Because the plan is actually to increase the community offer. and to increase effectively the investment in the community. So we have taken a conscious decision to do that, and we've done that effectively sort of last year, again, similar to the mental health investment standard. We agreed as a system to put more money into community services, which we've done. And I think one of the big ones that's going to overtake that, I think nationally, is going to be the investment in the primary care networks. I mean, the extra funding that's going to go into that for the likes of physios, paramedics, pharmacists, it is massive. I mean, that's going to be the biggest investment in community services that we probably will have ever seen, actually, and that is running into millions to do that, to bolster up that service. I think the other part that we're focusing more on now is around the home first, and trying to get people home and support them in the home. You know, if you want to know, you know, it's obvious when you think about it, isn't it? You know, the majority of beds effectively in Dorset are in people's homes. You know, that they're not in community hospitals. You know, they're in people's homes, and if we can get the support service around that, then yeah, that is the home first sort of model. I'll just see if Sally wants to come in on that, or even I think Charlotte's on the line from a continuing healthcare point of view, and Vivian from a local authority point of view, because it's really joining all of those services up to allow some of the community and the home first stuff to work. Sally's popped up first. I'll bring Sally in.
Thank you. I would echo what you've described, Tim, and just say I really express a slight frustration that I have around a focus always on beds and hospital beds, because if you ask most people, as long as they don't clinically need to be in a hospital bed, they would like the care and support in their own homes. So we need to get the balance right, what I would say, and that's what we've continually tried to do, is juggle those and trying to understand need the best we can. So the work that we've been doing, as Tim said and referred to, with our hospital colleagues, with adult social care, so Tony and Vivian and Jill, is really important around the home first model. Now, it doesn't mean that if somebody needs to go into a community facility, a care home or a community hospital, that's not where they should, they should go there. But a significant number of people with the right care and support can be supported at home. And actually, I would say that the national directive around this is helpful, because it makes it very clear and it's very specific about each profession and each organisation's responsibility to get people home in a timely manner, and that's been quite a useful incentive to really push the pace of change around this. It's not easy because it relies on other parts of our sector, such as the care market, both domiciliary care and care homes, in terms of the availability of care and support, but there is a real collective and strong commitment to use this opportunity to make that step change and learn from the work that we've done through COVID to really accelerate our plans in the first place around better care and support for people within a community setting. And we've done so much work, and the council have led on a lot of this in terms of our work, which you would know, Councillor, around wrapping care and support around care homes, and that's been really important to provide much better in-reach support to those individuals within the care homes, recognising the vulnerabilities of the people that live in them. Thank you.
Jill, if I could just come in on that, from an authority point of view, I know we're going to pick this up slightly later in our presentation, but I'd absolutely echo what my colleagues have said. As part of the ICS, we've been doing this very jointly approach, and the home first model is absolutely built upon your own bed is the right bed. And that's where we want to concentrate our support and services around the community, so people do not need to go into the acute bed when they could be best managed at home. So we will pick up this further as we go through our presentation, but absolutely, as a system, we're working very closely to make sure we've got the right beds in the right places and the right care to support people to remain in their community.
Is that okay, Councillor Orwell?
Okay, we'll come back to it, I'm sure. Thanks.
Okay, thank you very much. Could I have Councillor Gorringe now, please?
Thank you, Chair. It's actually a question for Tim, actually. About 15 months ago, St Leonard's hospital in the east was closed down, and that was taking something like up to 30 patients from Bournemouth and Poole Hospital. Do you consider that was a bad decision at the time?
So I can bring Richard in on this, but effectively we didn't. The ward itself moved into Bournemouth Hospital, so it's not as if it actually closed in that respect. But let me bring Richard in, and he can talk through some of the throughput that we've got through patients by doing that.
Thank you, and it's a good working example of the discussion we were just having with Sally and Tim and Councillor Orrell. So, in terms of the ward that was at St Leonard's, that transferred to the Bournemouth site, which allowed us to provide a lot more of the support services, particularly physio, OT, specialist input and so on, and medical input as well. And we actually found that the balance between more of the home first approach, which we've been developing a lot in the East, and that more intensive support for the step down, as Councillor Orr was referring to, actually meant that we were actually able to see about twice the number of patients through that same bed base. So it's not so much the measure is the number of beds. That's not success. The measure is patients leaving with a higher ability of independent living, and so it's the same medical lead and nursing leadership, but we're actually able to discharge and move those patients back to home or to a care home in some instances at a higher level. So by keeping that in place and using effectively the same resources, we're able to see twice as many patients benefiting. So it's very, very high level, but broadly that was the outcome of the transfer of the service. So I think it is a good example where moving a patient to an independent, an isolated community hospital, as opposed to investing in community services and supporting patients in their own home, and getting that discharge team and that pathway working, really does have big patient benefits in terms of returning patients to greater independence. So we definitely say that was the right decision that's had a good impact, and it's very much part of the benefit of investing in community, because our main delays aren't waiting for community beds, they're actually waiting for the community teams to support people in their own homes. So it is about perhaps moving on from what was great in the 1970s to actually what's working nowadays.
Can I just come back on that, Chair, please?
Yes, please do.
Yeah, I'll pick up on the point that John Orrell said earlier on, that patients in the east were being moved to the west, which was causing the problem. So that contradicts what you've just told me about Bournemouth Hospital having double the capacity of St Leonard's Hospital. Can you answer that one?
So I don't know exactly what that's referring to, but the process depends on what you define as the West, but patients will go into Wimborne and Swanage and others within the catchment, and there's no one operationally, but Sally might want to come in, but we do track when patients are needing, and some do, obviously do need community beds, and we are keeping and as Tim said, over the longer term we'll be looking to develop community beds, but it's within that range of options. There are times when the lack of a community offer supporting someone in their own home or an in-reach into a care home means that actually discharge teams are looking for a place that isn't an acute bed, because that's unsafe for that patient and not great use of resources for the patients who need acute hospital beds. In those situations, we're often looking for what is the next available place that's not an acute hospital bed. And there are circumstances operationally, particularly over the winter months, where you're then saying across the system, rather than have patients waiting in an ambulance to get into ED because there's 70 patients in hospital beds acute hospital beds who don't need to be there, you will absolutely look across the system, and day to day, week to week, there might be cases where the only capacity is in a community hospital, and in those circumstances we do look county-wide, and it goes both ways. But that's when you've got a system, as Councillor was saying, a system that is at max capacity, and then you're looking for the best place for that individual patient. And sometimes geography has to be traded off against the best place and safest place for that patient. And just to re-emphasise the point, an acute hospital bed for someone who doesn't need it is the worst place, because you will see deterioration and you will see risk of harm increased. So all of those sort of factors come into the daily operational sort of choice that we have to make for those patients.
Yeah, if I can just come back again on that, is obviously when a person comes out of hospital, if that person lives in, let's say, the east, and then they go into a home or a hospital in the west, one of the things that I've always been told, the family for visiting would then have to perhaps go 50 miles to visit them, and visiting people that have been in hospital or recovering from a hospital visit need to see their family. So I don't think that's a good idea, transferring people from the east to the west or the west to the east.
I think we probably do need to put this in perspective. The vast bulk of patients are actually getting more support now than they were 5 years ago in their own home. That has increased. And so where we do get into a situation where that service, those community teams, are unable to support any more people safely in their own homes, then we go into the suboptimal situation that you described. But I think that the east and west, if it's a patient who, say, lives in Christchurch and goes to Wimborne, that is something we try and avoid. There are circumstances where those sort of journey times do happen, particularly when the system's under pressure. However, it's in the context of more people than previously actually having that support in their own home. So it's about a balance and perspective here, but clearly we don't want patients going out of area, which is why we've particularly invested in placements in care homes, who are often more local. But again, that whole process of home first being the default, and then a care home, and that brokerage process, looking at the geography, all of those factors are absolutely taken into consideration, because we really don't want relatives and carers travelling. But the principle is we're really trying to get more people into their own homes so that those support networks are there for them.
Okay, thank you, Chair.
Okay.
Were you looking to come in there, Sally? Just appreciate you.
I would just want to take the opportunity to highlight and reiterate what you were saying, Tim. I mean, one of the key things from the clinical services review around the community offer was trying to match capacity and need to the location and place. So it was minimising the risk of people needing to be moved outside of their local area. We have not reduced the number of community beds in the east, so just to give you some reassurance about that. In fact, we've increased them. So we worked, for example, with the predecessor council at the time, Poole Council, now BCP, and we've jointly commissioned beds at Figbury Lodge with a lot of health wraparound support into Figbury Lodge. So we've increased the beds there, and we commissioned 10 of those beds, as well as significantly increasing the community capacity, investing in the care at home across the county, but including the east. So I would just say that I recognise what you say, Councillor. That was one of our key intentions, to match better capacity and need to place, so people would be closer to home.
Thank you.
Thank you.
Okay, thank you. We've spent quite a lot of time on this subject. I've got one more speaker, who is Councillor Pipe, and I think we'll then wrap it up and move on to the next agenda item, if that is all right with members. So if I can call Councillor Pipe.
My point has been covered, Chairman. Thank you.
Okay, thank you very much. What I'd like to do is to thank everybody who's come and spoken this morning. It's been a really interesting, really in-depth look at NHS recovery for Dorset. I think what we need to do with this, if possible, could we have your presentation, please, Tim? And we'll circulate that round officers, and we will consider whether we want to look at anything else, whether there's a more in-depth scrutiny on any of the topics would be useful. From your point of view, could you also look whether a scrutinisation of any items on your agendas would be useful to you, please? I always feel that scrutiny is a two-way process, so if we can help you, we would very much like to. If I can move on the agenda, as you'll see in the chat bar, I've just proposed that we take the urgent item next, so that the people here from the CCG and from Health will then be finished with the meeting and be free to either continue watching or to carry on with their own work. If that's all right, is that possible, Tim? Would you be okay to present on this?
Yes, could you just remind me what the urgent item is? All I've got is urgent item, but I'm sure we can. Is it the GP access?
Yeah, we have an urgent item to provide assurance given regarding general practice access and service provision. If it's possible, we took this as a late item onto the agenda, and I'd like to leave it on if we can, because we don't have another meeting until November. So
Yeah,
if you can just present on this, that would be really useful. Thank you.
We can pick that up now. Sally, are you going to present the slides that you had from your end?
I haven't got slides. I've got I think the paper was shared. Is that right, Councillor Taylor?
Yes.
To the members?
Yes.
So it's not a slide deck, it's a paper.
Yeah, the paper has been shared with members and it's also on the council website.
Okay, I'll hand over to Sally.
Thank you. Thank you. So I am mindful actually that we have touched on some of the elements in the paper through our discussions this morning. So I'll just pick out a few highlights and then, with your permission, take questions. So I would say it's been strange times, hasn't it, for all of our local residents, but also for services responding. So, and it's no different for general practice. And I touched on earlier in the meeting that we've been doing a lot of work with general practice around how do we build on the really positive foundations and the positive experiences that our local residents have with GP services, but the importance that they place in terms of the need to have good access to general practice, with a backdrop of recognising there is always room for improvement and that we do have variation. So we've been doing, at least for the last, must be 3 years now, since we took on full delegated responsibility for commissioning general practice services, a lot of work with them to help them develop resilience, recognising, like other parts of our system, there was increasing demand on the need for GP services, and also things like workforce challenges in terms of securing workforce. So the work that we've been doing is been multifaceted. So it's been looking at how we can use digital technologies, how we can develop a wider range of skill mix within our multidisciplinary teams within general practice, in recognition of the different presentations that people turn up at general practice with. So for example, people that have got musculoskeletal issues are probably far better seeing a physio first off than necessarily a GP, but having a GP there when they need it. That's just one example. Looking at how we support general practice to work with other partners, and there's a good history of this within Dorset, whether that be community services, the voluntary sector. So the introduction of health and social care coordinators to really help particularly those people that are frail and benefit a lot from continuity of care, how we develop and support a more coordinated approach around early engagement with those individuals to try and reduce escalation of their needs, but being able to rapidly respond to their needs if they do escalate. So I'm mentioning all of these elements of work because they were really important when COVID came along, because they gave us a really good base and foundation to be able to mobilise quickly and respond to what was very strange times. So of key importance when COVID started was how do we maintain access to general practice, but in a way that made it safe for patients and didn't put them at greater risk, and also safe for the workforce that were engaging with general practice. So quite quickly, because we've been doing this work around our digital platforms, the practices were able to mobilise a triage first model, where they were triaging any calls that came in or any contact to general practice to work out whether they could have a conversation with them on the phone, whether video consultation was appropriate, or whether they clinically needed to be seen face to face. We did experience, as the rest of the NHS did, a real drop-off to begin with in patients making contact with general practice, because I think people were generally scared. That is significantly changed now, and actually, if not, contacts with general practice are absolutely at the same levels of before COVID, if not greater. So the demand into general practice is certainly picked up. We were given a directive, a national directive at the beginning of COVID, that general practice was to stop all routine work, and they needed to focus on being able to grow their urgent capacity to be able to respond on the same day, and also to be able to segregate the management of patients with those with symptoms of COVID and those without, which is the hot and cold sites that Tim referred to earlier. So they very quickly mobilised into being able to respond and segment the way that they delivered care. Obviously, getting access to PPE was a bit of a problem to begin with, but that did get rectified, and also how they worked together across practices to ensure that there was that appropriate access for patients. We also have worked really closely with organisations like Health Watch to understand what people's experiences have been accessing general practice through the COVID period, recognising we escalated our programme of work, for example, around video consultations. And the report that Health Watch has published, which you may have seen, was actually really positive about people's experience using things such as video consults, but an absolute recognition that that doesn't suit everybody. One, clinically it might not be appropriate, they may need to be examined, or secondly, for some of our population groups, that it isn't suitable for them. So having a mixed economy of a service offer from general practice is what we've continued to strive to do. You'll see in the report we've given you a bit more detail that sits behind that, but also to give you reassurance, there's been quite a lot of media interest this week around some concerns about practices not offering face-to-face, and that is not the case in Dorset. Our practices are offering face-to-face, and just to give you an example, in the last week we had 60,000 face-to-face contacts across our practices across BCP and Dorset area, and it was about 66% of the total contacts, the rest being telephone and video consults, so more than 50% were face-to-face contacts. So that should give you some reassurance. But I can't underestimate that it's been quite difficult for general practice as well, and we continue our work to look at how we can address any variation in access and listen to our local populations when they are having difficulty. And it often will be to do with things that a practice may be struggling with, workforce shortages, or they need support with looking at how they manage their demand and capacity that comes through the practice. And I have a team of people that work with the practices to look at how we can support and continue those developments even through a time of managing, and we're still managing with COVID. As Tim said, we are concerned about the rising cases again, so we are still living with COVID and needing to adapt accordingly. I'm happy to take any questions. I hope that was the appropriate level of summary for you.
That was really good and really useful. At the moment, it was very good, in fact. At the moment, I haven't got anybody on the chat bar asking to speak. Is there any members wishing to speak on this paper?
Could I just a
Sorry.
Tentative question?
Ask Councillor Pipe, please.
Yeah, sorry, Chairman. Although my previous question was sort of answered, I've just been made aware now of not a friend, not a colleague, just somebody I just happen to know was referred to their GP for a suspected COVID. So she's contacted the national booking system. She lives at Creekmore, and she's been told to go to Bristol for a test. Is that real?
To be fair, it might be. So Tim talked about this earlier. So I would say this isn't anything to do with general practice. It would be my first reference. This general practice have got absolutely no influence over the national portal and testing. In fact, if anything, the concerns that the public are experiencing around access to testing is having a negative impact on general practice, because lots of patients are phoning up the GPs asking about tests. So it is a concern across both general practice and for our public around access to the national portal testing system. And I'm sure you've seen it all over the national news with ministers being interviewed on this. We can't deny it is a concern. It's a concern for us as well, but it isn't something other than lobbying, which we continue to do, to raise the concern about the impact that that's having to the public and testing. But as Tim said, we do have routes for testing of our frontline NHS workforce, but it is a concern about the wider public access to testing.
Yeah, well, the concern now is that she's saying, I'm not going all the way to Bristol. I've got three young children. She's a single parent, and she's been told to go to Bristol. She lives not 100 yards from a testing station.
I mean,
it's ridiculous.
It is a concern. I think what I would add, though, is, and this may not go down all too well, but testing is really, really important, and we hear about that all the time. But the most important thing is the self-isolation messages. So we are doing all we can through our comms to get the key messages out to the public, recognising that we have got limited influence. But the key messages that will come back, and I think public health would say, is that the importance of self-isolation if you have got symptoms, whether you have a test or not.
Please just ask Councillor Miller to come in, Councillor Laura Miller, if you'd like to come in and introduce yourself as well. Please, Laura.
Hi. Oh, hi, thank you, Chair. Yes, sorry, I'm just trying to get my video to work. There we go. Yeah, I just wanted to come in, Chair, if I may. I'm Councillor Laura Miller, and I'm the Cabinet Member for Adult Social Care and Health at Dorset Council. Yeah, I just wanted to respond to Councillor Pipe. I'm very happy to pick up individual cases offline, but we are aware that this is a national issue. We are aware and we are lobbying on this. Everything that the previous speaker, Sally, yes, has said, I absolutely concur with. We will have a briefing going out for members later on today, which should give you a little bit more information around the sort of public health aspect of this locally, because, you know, I've been in that situation of trying to book a test and being sent to Cardiff. I think I was also sent to the Isle of Wight. So we are aware of this, very much so. We are lobbying on this, and we are putting together a briefing for everybody so that you're aware of the sort of history and what's being done locally as well, to try to get the messaging out and really give people the sort of toolkit to help when their constituents get in touch and say, I'm in this situation, because we know that a lot of people are. Thank you, Chair. That was very kind of you to let me jump in.
Okay, thank you very much, Laura.
What I'll do then, Chairman, is talk to Councillor Miller offline and give her the details as I know them. And I'm sure she'll try her hardest, as she always does.
She's brilliant.
Thank you.
Thank you very much. Are there any other questions? I can't see any in the chat bar. So could I just take this opportunity to thank everybody from Health for coming today and for the presentations. I found it really, really useful, and thank you so much, and look forward to working with you in the future. If I can move on to the next agenda item now. As you will have seen in the chat bar, I've missed the minutes. I'm intending to take the minutes after the main presentations. If I can go to, oh gosh, Teresa for the presentation on children's services, please. Good morning, Teresa. And apologies for forgetting your name briefly.
We're absolutely fine, Jill. That's great. Thank you very much. Okay, so I'm going to just share with the board a presentation on children's services. I think our conversation really was one of it might be just a helpful time just to have a sort of a benchmark around where we are within children's services in the local authority and the partnership generally, and to do that via a presentation. So if it's okay with you, I'm hoping this is all going to work seamlessly, of course. Oh, not that one. It's the danger, isn't it? You click too quick. Okay, let's banking on the fact that everybody can see that screen, and I'll just talk through where we are, and certainly with a strong focus on scrutiny where we are. So in addition to this scrutiny board and other processes, we have obviously scrutinised significantly within children's services, probably more than most other services within the council, by a range of external scrutiny processes. So I just wanted to kind of catch up on where we've been in the last few years around those processes and bring that right bang up to date. So generally within children's services you have full Ofsted inspections every 3 to 4 years, and our last one as a service was in fact with the predecessor council, Dorset County Council's full inspection was in February 2016, when the council was deemed, council services were deemed to require improvement, and there were 18 recommendations at that time. That was then followed through with a new form of inspection, which is more in line with where we see the future of inspection going. So this joint targeted area inspection, a JTI, and that's, as it says in that smaller box beneath, a joint inspection delivered both by Ofsted, the Care Quality Commission, the CQC, HMI Constabulary, Fire and Rescue and HMI Probation. So complex inspections where they're looking at the vast range of partners, but as people are aware, I know, the working together requirements for the local authority often give us as a local authority lead responsibility in some of those areas anyway. So it looks at how well we're doing things together, and it looks at how well we're giving leadership to that. That was a fairly critical inspection of the partnership, and it was a significant action plan required following that. If I jump to the right hand side then in terms of actual timeline, so before that really came the local area SEND inspection, and again a joint inspection between CQC and Ofsted. And again, sadly, that inspection in January 2017 had a follow-up action plan that was to be monitored by the DFE with some real concerns about partnership and how we were working with families around SEND. I'll come back to that in a moment because we have an update on that that's very live, but in the middle there, so in October 2019, just at the end of last year, we had a 2-day focused visit wherein Ofsted were checking the arrangements for children in need and children subject to a child protection plan. And that doesn't have a single outcome, but more of a narrative judgment. And fundamentally in there, the message was that they had looked at our proposed changes for this year and they thought that they were probably the right way to go. So coming up to date with the next activity for us around regulation inspection, the inspectorates have literally just turned back on. So Ofsted are back doing inspections and so is CQC, and we were pleased actually to be offered the chance to have an interim focused visit around SEND, and we've just been offered that. We're expecting a phone call on Monday, and that will be for an on-site inspection of week of October the 5th. And that inspection has a particular view and a particular focus on how well the partnership, so that's ourselves and health colleagues, so Sally and I are working together intensively in the next few weeks to look at how well we've managed with families with children with SEND during COVID. That will then form part of a national report, and we'll obviously have a feedback session within that too. So from where we were to where we are, as I've said, we were in a position, so that standard from 2016 still stands, although 2017 and 2018 were more leaning towards inadequate, and really gave us a very, very challenging position to respond to around a range of areas of working. The focused visit 2019 took some view that we were going in the right direction. and certainly my position is that all of our improvement and all of our continuous improvement is around how we get to this vision that we absolutely have running through everything we do, which is wanting children to have the best time in Dorset, where communities thrive and families are supported. And we do all of that through a range of strategic partnerships. So we can't do anything in children's services without doing it with others. So we work really closely with health, police and our schools. And obviously during the last few months in particular, our work with schools has been hugely important, and I'm deeply impressed by their ability to get us where we need to be with having children back in school. One of the big achievements for September has been to last week see attendance in Dorset schools at 94%. We think that was probably the best in the country. I'm always a little bit cautious about those things because there's only one way to go, but I'm deeply impressed by how schools have got children back, and you know, we know that that's the best place for our children to be, and we know that actually that allows us to work with those children who may have had a more difficult time in lockdown by ensuring that they're back into that network. So the safeguarding work, the early help work, the good educational outcomes work we're doing across the piece are all done best when we do it together. So we have a range of shared values, and we are changing some of the culture and cultural messages from the predecessor council position. We really want to be in a place where we're working with our families and not doing to or for. So it's really important that we support children to be at the heart of their family, at the heart of their communities, and wherever possible that children live within their families. So it's not saying that we won't have any children that come into our care, we clearly will, but our absolute endeavour is to empower families to be able to be the best they can be. So we have 3 particular approaches at the moment, which colleagues will become more and more clear around, and it's around how we work with Scrutiny to really focus upon those. So we are still in a space where we're looking to strengthen our services. And so we have a detailed strengthening services plan that is a partnership plan, where together we've worked through an 18-month programme that's now well underway into the first few months of that programme to strengthen and improve the early help outcomes, the safeguarding outcomes and our children in care outcomes. We know we've done a lot, but we've got more to do in terms of closing the gap for some of our children, closing the gap for some of our communities. Not all of our children are presently having the best education, so as part of our Children, Young Peoples and Families plan, we're looking at having a series of processes and programmes within that, which I'll come on to. And then clearly each individual organisation of the partnership, police, health and children's services, have their own transformation processes, but we're linking all of those together. So yep, I think I've said that one. So Children, Young People and Families Plan. So this is just about due to come to Cabinet and Council in the autumn. It was just been signed off by the board last week and has now 6 key priority areas within it. We'd started off with 5 draft positions. We felt best education for all, and for that will also be our SEND delivery board. So we know that children who have an education, health and care plan have in the past sometimes waited too long for that plan to be activated, have sometimes found it difficult to access the support they need. And I'm very keen that where that's right for children to have an education, health and care plan, they have one, but where it's right that we can offer services and support prior to that being required, we do that, and hopefully in doing so get early help at the right time for our young people. Going round the wheel, the best start in life. It's very clear from our deep dive in terms of our performance information to underpin this plan that not all of our children are having presently the best start in life. And so some of the indicators we've looked at around this particular part of the programme has been around school readiness. So all of those things that we understand in terms of children being ready to learn, children having the necessary skills, the necessary language, the necessary self-care behaviours. And for some of our children, for too many of our children in particular areas, they're not deemed ready for school. And when we look at an easy solution to that often is for them to be in good or outstanding early years provision. Well, many of them are already in good or outstanding early years provision, and really what we've been looking at in this piece of work is the understanding that the development of language and the development of attachment for the very youngest from conception, particularly for those first 1001 days up to 2 years, is absolutely an area for us to focus on. So colleagues in public health are leading that work stream across the partnership to really have a focus on those first 1001 days from conception to 2, to make sure that our children have all of those necessary, hugely important speech and language, attachment, and really good health outcomes at the beginning too. Delivering locally is largely a big part of our blueprint for change work around reshaping the way in which we deliver services so that they make more sense to our communities and they make more sense to our partners. So we've been through a significant change programme which has resulted in 6 locality areas where people are singularly managed, whether they're working in education, early help or social work, to be able to work around a family regardless of the needs that they have. They can have a single practitioner as a outcome going forward. Young and Thriving is the work stream that's looking at our young people. It's got some targeted youth work investment has gone into that part of the business, and an adolescent service for young people at the edge of care. Much more development going on in there, and we're working with colleagues across North Yorkshire to look at a particular approach to working with young people at the edge of care, which we're very excited about, and links very strongly to our good care provision and the development of good care provision across the county, and beginning in particular focus on the Weymouth area with proposals around care provision in Dorchester Road. Best Place to Live was actually a final priority area which was added to the plan following the campaign I Live in Dorset, which is just quite a fantastic campaign where we asked children and young people to tell us what would make Dorset the very best place to be, the very best place to be a child in. And the responses, I mean, I have to kind of hold fire on sharing them because we will be launching them in the next week or so. The young people are just incredible. The level of musical, art, creative activities that they've undertaken to communicate to us what needs to change for them to consider Dorset to be the very best place to be a child. And a summary of that, as well as some of the other issues that we'd already identified in our 5 priorities, was that it needed to be the best place to live. And that was often about access and accessibility and a sense of feeling welcome in their diversity, whether that diversity was disability or race or any form of difference. So we've developed the plan to incorporate that, and it's really pleasing to see that feedback from young people. And I tell you what, when you see their work, it's impressive. So as I've said, we've already implemented the Dorset Children Thrive model for the localities, and that visual is just one of the ways in which we want to kind of show how we're wrapping all of our services around having children and young people at the heart, and all of those different professional roles that are described there are working together in a locality space so that we've only been going about 2 weeks. As you'll get to know your head of locality and strategy, you'll be able to understand and appreciate and access a way in which they can work with families in a really integrated way, bringing together all of the professional disciplines to wrap around the family's needs. And what that will mean in terms of how it will feel different for families is that if you have an issue in school, your practitioner who's working with you to support you in school will be the same person, or certainly working in the same way as the person who's working with you at home. Whereas previously, unfortunately, families told us they were often given contrary and contradictory advice, depending upon which part of the system staff were working in. So those design principles, again, making sure families are at the heart, getting it right first time where we can, and continuing to strive to learn and close those gaps. We do want to be digital by default, and we want to deliver services wherever possible, where families can self-serve, where they can access help and support quickly. We've all learned a lot in COVID times, haven't we? And in lockdown, we've had to do a lot of our work digitally. Obviously, lots of my staff have never been off the front line. We've been visiting children throughout. We've sadly been significantly challenged at times by some very challenging safeguarding matters throughout, and staff have absolutely been working out of their homes and in and out of other people's. But we've also been doing much more online where we can and where that's appropriate for families. So child protection conferences, for example, have in the greatest part been an online meeting. We've done a lot of feedback from families around that, really wanted to understand what that was like for families, and it's really important that there's an equal power base around being able to have access to a camera, being able to be truly engaged in that meeting, and that hasn't always been the case for some of our families. Some of them have only been able to phone in by phone, so we're looking at really thinking around how we can equalise that. Some people have really enjoyed it, really enjoyed that process and felt much safer in that, and other people have already communicated to us that they would like to be back in a room with the chair of the Child Protection Conference at least, and so we're looking at doing a bit of a mixed economy there. Some of our children have really appreciated and enjoyed having their reviews if they're children in care online, and some of them very much haven't. So we've continued to try to respond to the different ways in which children and young people want to engage with us too. Very briefly, our children's advice and duty, the CHAD, you may have been familiar with the front door being referred to by that. So it's important for us to continue to pay attention to what is developed nationally as good practice, and also to really pay attention to locally. So we've amended our CHAD to also incorporate our multi-agency safeguarding hub. It becomes an acronym soup if we're not careful. It's a MASH and a CHAD and an early help hub. But fundamentally, in the front door for children's services, and that's based in Wareham, we now have our multi-agency safeguarding hub, our MASH, which was previously in Poole Police Station. And that's where we make joint decisions with police and health colleagues and others around safeguarding issues. And we share information based on all the things that we've learned over the years about how important it is to share that information around the safeguarding arena. And if that requires a child protection investigation, all of those colleagues are there to be able to do that together. And we then, if it requires a children's services social work assessment, that can go through into all of the localities and any of the areas via the CHAD. But if it doesn't actually require that level of intervention, if actually the help services that are required are more early help, the early help hub also sits there in an integrated fashion and can access families into help in the right places, either of our own early help services or of other parts of the partnership. So what that means is that any one contact into the front door means that people can access the support in one place, and it's our work to navigate you through where that is, and we do that with our partners. That's had a real bonus already for us. We're already seeing all of the things that are important happening. So the rate of referrals, it's really important that we only get the right referrals into the children's front door. It's about eliminating snowstorms. One of the biggest risks for us as a children's services department is that if we have too many missed referrals coming into the front door, we end up not being able to see the very things we need to be able to see. So it's really important, and in fact we are judged by Ofsted on how good our referrals are. So that can feel quite tough sometimes, but it's really important that we support people to only make the right referrals. And we're clearly doing better at that in terms of the numbers coming down much more in line with our statistical neighbours. And you'll see throughout this presentation, we now have access to fantastic performance information, and we scrutinise it and scrutinise ourselves really very thoroughly. I mean, I could probably give you a presentation of 200 pages of performance information, because in children's services, yet again, we have to reply to central government demands around performance information every month, and a huge level of depth and detail. And so the important thing for us is to be able to know which ones are the important things to pay attention to, and the rate of referrals is really important in that. Our police colleagues have done some fantastic work with us to make sure that, again, their referrals, their public protection notifications, are only the right ones coming through to us. So I share a concern with my police colleagues that there does sometimes seem to be people revert to calling the police for some very, very banal and quite minor incidents that really don't require any further investigation, but they are obviously required to record those. Not all of those are appropriate to come into children's services, and the police are presently triaging them in a much more effective way. And so we've seen a reduction in public protection notices. But we are also making sure that our early help hub look at those and consider whether there is a story around multiple public protection notifications as well. Re-referral rate is also coming down, which is good news. So we have a range of areas that we feel are the right places potentially for future themes for scrutiny, but really open to having a debate about these. But these are our areas where we are giving conspicuous care to, and we're giving conspicuous care because we have some concerns about how that's working at the moment. So children missing, and children, including children missing education, and children and young people at risk of exploitation. We just give this conspicuous care all the time, but I'm afraid it continues to be a challenge. And in lockdown and post-lockdown, it will continue to be something that we should be absolutely relentless about in terms of trying to get ahead of what are very organised crimes and very organised individuals at times. And children, clearly the safest place for children is if they're in school. And if they're not in school, their risk is increased, and therefore we deliberately put children missing education and children missing together because we consider that risk to be just the same. And then children and young people at risk of exploitation, either from sexual exploitation or criminal exploitation, or becoming part of a drug running group, is something that we continue to focus on. School exclusions, the same, read for the above. If children aren't in school, they're not safe, and if they're not in school, they're not going to be having those educational outcomes that we focus on. So the heads for the Dorset schools and myself share this as an absolute obsession, and we are committed together to see those school exclusions coming down. They were far too high in recent years. Special educational needs and disabilities is everybody's business. Children with special educational needs often don't have an education, health and care plan, but they do require us to again give that conspicuous care to their outcomes. Their educational outcomes aren't where we want them to be, and too often their emotional well-being outcomes aren't where we want them to be either. So that remains a kind of real area of focus for us. Early help, we have invested significantly in early help. Blueprint for Change has determined that we would put more frontline practitioners in place as we thinned out management structures. We have been able to achieve that. It's absolutely crucial that that has impact, because our huge challenge, as you'll know, is that we have significant numbers of children in care and significant gap in the number of placements for those children in care. Now, clearly much of that is reported to the Corporate Parenting Board on a regular basis. But the reality is, in addition to wanting to have better outcomes for those children and better placements, what I really want is more children living with their families and their communities. And so early help needing to have impact in that place is a real important place for us to focus. We've got the annual report for the Children, Young People and Families Plan, so that would be proposed for June. And the Strengthening Services report, again, you'd want to see line of sight, I think, on that in terms of seeing how the progress is going forward. And then educational outcomes, as you all understand, can only report at certain times, and who knows what that's going to tell us in December and January this year. But we can find ways of considering what it is that's telling us at the moment. So that's it from me, Chair, and happy to take any questions.
Thank you. That was a really interesting presentation. I don't know. Can you take that? I can just hear myself coming back all the time.
Is that better?
Oh, that's better. Thank you.
Oh, my apologies. I'm sorry, I didn't realise I hadn't got it on. I'd been sat here with it on all the time and then taken it off. I think my apologies. Okay.
Thank you. At the moment, can I ask for questions, please, from the committee? I've got nobody asking questions at the moment. No. I have to say, I thought that was a really interesting presentation, and certainly your guidance that you put in for the themes for future scrutiny are really, really useful. If we can take that forward into the forward plan and look at schedule in some of those or all of those in, that would be really useful. And thank you for your time.
Great. That's really helpful. Thank you, Chair. So I'll speak with Democratic Services and we'll get those scheduled in. And if there's anybody on the call now or later who wants to add anything else in, really happy to do that. I just think it's really helpful for us to, because as you know, certain things are reported at certain times, so it's helpful if we've got forward notice of when and what.
Okay, thank you very much.
Thank you.
If I can now go over to Vivian for her presentation, please, for adult services.
Thank you so much, Chair. I'm joined, as you're aware, by Tony Meadows and Jill Vickers. So I'll start. Good follow through from the children's presentation in terms of where we are, what we want to do, and the principles of which we're working. So one of the questions that the committee asked for us to be able to look at, thank you, Sam, is to run through what we do, how do we do it, and how are we set up, and how do we work across the partnership, and what are the key issues in adult social care that we are working on, both pre-COVID and post-COVID, and what are the key drivers for our service. So I'm just going to take us through fairly quickly before we move on to the actual what does the service look like, and whose needs do we meet, and how do we work with people. So Sam, if I could have the first slide on the statutory context. So this just gives committee members, I'm sure you're very familiar with this, but we just wanted to clarify, because I know in conversations that we've been having about, how broad is adult social care and what does it cover. So we are, I think all of you are familiar with the Care Act, which came in 2014, which brought together our statutory responsibilities and the legislation. So we are responsible for everybody over 18 who has a need and is eligible under the Care Act. So that has a need for care. So we see a very small percentage of all the residents in Dorset that would come near adult social care. We assess their needs to offer support. We also one of the responsibilities that the Care Act gave us, most importantly, was support to carers and the providing for carers needs and an assessment, and making sure we work in partnership not only with our residents but also those residents that are carers. We also have an important role and a responsibility to assess under the Mental Health Act, which we will go into more detail in a little while. For those people that are requiring care and support, we also have a responsibility to assess under the Mental Capacity Act. So it's for those people that are needing to make decisions about their care and support and how they live. And part of the process, we also have a best interest assessment. So it's decision specific. So if people are going into care, or they've got financial decisions, or they've got health decisions, that comes under that act. The deprivation of liberty and assessment, that's also to do with people that are may or may not be deprived of their liberty, say in a care home with access to exit, or care home, or to receive care in the way that. I'll move on to safeguarding, so really important part of our business. We work very closely, our partnerships on this. This is really important. Children's Services to assess for safeguarding, to make sure that people are safe and able to live the lives that they need to be living. We also have a responsibility for people that are coming out of prison, and leaving the armed services that may have needs the assessment under the Care Act. And most importantly, which wasn't previously under statute, was that the local authority and adult social care has a very large responsibility for market shaping and resilience and sustainability. And as you're all very aware, that has come absolutely into the fore if you weren't aware of it before, then during COVID, the impact on our and the care market and how we support the care market to act has become more and more important. And we have a responsibility not only for the provision that the local authority contracts, but also the wider for all provision in the geographical boundaries of the local authority. More on that when Tony takes the role. So next slide, please. So I've touched on most of these. So in adult social care, we really want to work much more in partnership with our residents, and we see that as a really important to how historically there may have worked in the past. I think a lot of learning that we've had is that it's not, as Teresa was saying earlier, we want to work with people. We don't do things to people. People are the best experts in their own. Our responsibility is to advise and give info, but it's not to do things to people. Even when we've got a statutory responsibility, our aim is to work in partnership in a way that meets their needs and that people are able to stay well and independent, and they can build up. It's important to them that they're able to do the things that really matter, and that we support people to stay well and independent, and also contributing, as many of you have had very positive experiences during COVID. The work that's gone on in the communities for people to support each other, and how communities have come together, and even people that were shielding, or even people that were very vulnerable, have actually shown to all of us that they have got real strengths and assets to give. And it's a combination of all of those things that my colleagues in adult social care and I and help colleagues are really wanting to build on, and not just do things to people and to give them care. This is about building for the future. So just quickly skipping over, because I'm conscious of time, but just wanted to put in your line of sight the key national drivers for adult social care. We've talked at length a little earlier about the hospital discharge requirements that came in during COVID. This was a new piece of guidance and legislation which we're working on, and during the course of this presentation we will talk much more about what that actually means and how that impacts and how important it is to get right for our residents. Tony will also touch on the Better Care Fund and how that fund supports the work that we do together as an ICS system, and it supports the work of adult social care to deliver a joined up approach to care that we give people. Many of you will be very familiar with the safeguarding legislation and also making safeguarding personal. The response in everything we are trying to do is to listen carefully, to make sure that we are hearing what people are telling us. When they have unfortunately been involved in a safeguarding event, that we hear what people are saying that they want to have a resolution to, that we listen carefully to that and don't prescribe what that should look like, and we work alongside them to make sure that the outcome that they want to get out of a safeguarding investigation or a complex piece of work we're doing with them, that we are providing them with the outcome that they require, that makes them feel safer. We're going to touch on Mental Health Act and mental capacity, so I won't go into that any further, but we just wanted to give you that line of sight. Our regulatory context, it is very different from children's. It's changed over the years in adults, and I have no doubt that it will change again. But presently, we don't have the same systems as children's do, although we do have to work very closely with Children's Services and Teresa's and her workforce and the partnership, because we too are regulated by OPED and some of the services we provide for our younger adults and our young people, and as we're taking part in the Ofsted, the SEND Ofsted that Teresa mentioned earlier. We are absolutely work hand in glove with CQC, the Care Quality Commission, and Tony will talk a little bit more about how that affects our day-to-day work and how that affects the work that we do with our providers and some of the care homes and some of the supported living providers. Just to put on your radar the overall the context in which we work and how we look at our regulation and our benchmarking is very much through a peer review lens at the moment. So that's in the main led by the Local Government Association. We also, as a region, have peer reviews on specific items. So it's very often that we will have one on safeguarding. We'll have one on the local offer on co-production, or on how we are meeting people's needs from assessment to services. So there's a process of that, and we are in the process of looking at a light touch peer review in the first instance for safeguarding across the partnership. So that's something that's yet to be agreed and will be looked at as part of our safeguarding partnership. So this is just a slide to give you an idea of how some of what we do fits together. I don't expect you to go through this, but we just wanted, for the purpose of scrutiny, to be able to see how the conversations that we've been having throughout the morning with the ICS and with children's and adults, how that begins to form and land in the adult arena. So I'm conscious of time, so I think without further ado, if I can hand over to Jill, who's going to talk us through what happens on the ground and where we're placed and how that works with our ICS colleagues. Jill, over to you.
Thank you, Vivian, and good afternoon, everyone. This slide is really just to show you where our current services are, together with other council and health services. So I'm not planning on going through it in detail, but you can see that the little key with the people and a person in a wheelchair is where our area services are, and the little like Red Cross is where our specialist teams are, and then the stopwatches are out of hours service. Now Tim and Sally talked earlier about Home First, and we are all working as a system to deliver that. And one of the things that we need to do in order to do that is to move to place-based services with multidisciplinary teams. So we're still working on it, but it's likely, because we need to be coterminous with our health partners, that may well reflect these primary care network areas that you can see in the different outlined colours. Thank you, Sam. Next slide, please, Sam. Thank you. This is just setting the scene, really. So this is the demographics for the year 2018-19, and you will see from the left-hand box that Dorset Council rate of requests for support per 100,000 is quite a bit higher than the England rate and the regional rate. But on the right-hand side, if you look at the right-hand side box, we do manage to keep the number of people who access our longer-term services at what we see as a reasonable level, so trying to take that approach of getting more community support in there. So that's setting the scene. I'm going to hand over to Tony and then I'll pick up on that a bit further on.
Great, thank you, Jill. Good morning, everybody. Oh, sorry, it's afternoon now. So we've been talking quite a lot, obviously, around the impact of COVID and where we are. And obviously, over the months, there's been quite a significant focus on residential care very specifically. I think one of the interesting factors is, obviously, we're seeing a lot of vacancies at the moment in care homes. But even before COVID, what we were seeing is a reduction in demand for what I would call sort of your more regular residential care. We're seeing about 6% reduction year on year. And COVID has really amplified that. It's basically increased vacancies to around 500 empty beds across the Dorset footprint. Put it into context though, we've got 125 care homes and, oh crikey, probably about 5,000 odd beds. And that's not just people we contract with, there's a few homes we don't. But we've talked about Home First and the fact that what impact is that actually going to have? I think one of the things that we need to look at on that, Home First is really not just about discharge from hospital. It's also about prevention of people going into hospital. It is actually making sure that the right services are in the right place. And Jill's already mentioned that the wraparound of community service is really, really key to that. But what that means for us as an authority, we've got all of these homes and all of these beds, but we will begin to see that demand getting sort of, I suppose, increasingly different for residential. We're going to see more of an increase around the top end dementia and nursing. But it also means we need to have the right accommodation for people because, okay, your own home or Home First doesn't necessarily mean where you're living now. It could mean an extra care facility. It could mean different forms of accommodation. But very much strategically, we are looking at how that can be developed and where we can look at places to start developing that type of resource to give people, yes, their own front door, but the build quality and everything else that can support those sort of frailty situations and everything else. I think the key to a lot of the conversations that we're going to be having over the next sort of few months and years is actually making sure that we've got the right care in the right place. But that doesn't just mean from the social care perspective. As I've said already, that is very much about the system, the whole care system, because as people do remain at home longer, their needs are going to be different. So it does mean that maybe there's a standard home care sort of provision wouldn't necessarily deal with all of those needs. So it's how we have the right therapeutic inputs and the right services to support people in a broader sense. So it is around those community health facilities being there and wrapping around as well. And that is why when we start looking at things such as bed capacity in the event of another COVID outbreak or anything like that, we've got to make sure that any beds that we do utilise are in the right place to enable those community services, etc., to be wrapped around and give the right provision. I think one of the key things around that as well is that we do see quite a lot of spikes. So part of the Better Care Fund is obviously how we support the system through winter pressures. Now, winter isn't just around COVID. Obviously it is this year, but we also have norovirus, we've got flu, and we've got all of those seasonal pressures which will really increase that pressure. On top of that, as we've got the issues around testing for staff, that has further implications. So our relationship with providers and other agencies out there is really, really essential for us to keep sort of going. But what we have to look at in that is obviously there's a large sector. It's a very, very large social care sector, and it is obviously not just the people we contract with, as Vivian said, under the Care Act. We're also responsible to the sustainability and the viability and ensuring quality of a lot of the other organisations out there that maybe only normally touch what we would label as self-funding individuals. So we do really sort of have to manage that process, and that's where the relationship with CQC and other partners really comes in. So we do monitor intelligence in terms of the capacity of all homes. We're in almost daily contact with most homes in the area. We look at safeguarding, we do quality inspections from that point of view, but what we have to also then do is stratify where our our real support goes. So we can spot early where a home begins to have difficulties, and quite recently we went through that situation. There was a care home closure due to quality standards recently in the area, and we successfully managed that situation in a 4-week period, and had very positive outcomes for the individuals. The other side of Home First as well is really what is the offer when somebody is discharged from hospital, and a lot of that is ensuring that what we're not doing is just waiting to push people out and go down the usual roads. We're actually putting a lot of resource around the hospital door, if you like, and making that easier for people to access. It's not just about standard reablement, it's enabling home care hours to be available, and if needed, there will be bed capacity. But the key thing is that it's about actually getting people out, getting the therapy wrapped around, and then the social care assessment, because an assessment in hospital is really not going to be ideal for anybody. Getting somebody into a better place where that assessment of what their long-term opportunities are is much better in terms of the individual outcomes, and also much better for us in actually knowing what we need to plan ahead for. One of the things that, again, we're going to see is if complexity is beginning to increase in terms of when people are accessing services, and especially in their own homes, and also when people go into residential care, it means that the needs of those providers in terms of the staff, the skills gap, etc., is going to be quite acute. I mean, one thing I'd not put on here, but I remembered when I was just writing some notes, I know we had some comments about unions, etc., with regards to the complexity. Just a note that we have actually just signed the Unison Pledge for Stop the Spread, and our commitment to how we're working with the sector and how we're working with providers to support their staff. One of the other things we're doing, we're just about to launch the Dorset Social Care Initiative. And the idea of this is we're looking to actually work with the sector to offer training, recruitment, and a big advertising campaign that really raises the status of care workers. Because yes, we've done the clap on a Thursday, but what happens now? How do we really support people? And how do we create a pathway where there's training and recognition to give us some more parity against maybe some of the colleagues in the NHS in that respect? The other side, just to finish on, is obviously COVID hasn't stopped from our point of view. We never reset properly. We have been continuing to manage this situation. Things like PPE supply and infection control is a continuing issue, in that we are continually monitoring it. We're continually providing the PPE on emergency basis. And during the whole conflict, what am I saying? It felt like it at times. During the whole COVID scenario, I am proud to say that no provider actually ran out of PPE. There were a few near misses, but we got there, and we got those provisions out in a very, very efficient way. So that's not just about us as social care, though. That's about the council and the way colleagues with highways, etc., really flex to support the community. We've got a lot of other work to do, though, as we move through in terms of preparation for COVID. It's also very much around how we can support testing. And there are a lot of issues with testing. We know that, that's been discussed, but we are continually feeding in those issues. We're hearing it straight from those care homes and actually advocating on their behalf. It's also around domiciliary care as well, and we're having to lobby to a certain extent because testing obviously isn't as prevalent for domiciliary care workers who are out in the community. So we are pushing these through on a continual basis. So COVID is a huge area. We have to look at transformation, though, in terms of how we can actually move forward and look at better outcomes for individuals. So if we can move to the next slide. So the pressures pre-COVID were very much around changing complexity, aging population. And in reality, our community offer, the way we were working with the voluntary sector, the way we were looking at the assets and strengths in communities, we were very much coming from that deficit point that we do with people. And we'd quite often parachute solutions in rather than work with communities and actually develop things. I think we've learned a lot through COVID about actually we weren't doing it right and we need to work differently. And part of that is actually how we engage with members to achieve that. We do know that we've got to deal with the shortages in skill and resources in some parts of the county. Rurality does have a cost. You know, the travel for some workers is really significant, and when they're, you know, they're trying to actually get around as quickly as possible to give the care on time. Are there different ways we can do it? Are there different models of provision? And as we see care homes changing in the way they're working, are there opportunities for some of them to actually maybe not be just offering beds, but maybe outreach into their local community and increasing the resources? Housing and accommodations, very, very difficult in terms of affordability and everything, and through things such as building better lives, we want to strategically look at not only how we provide care in communities, but how we provide that valuable accommodation for key workers that is affordable and in the right place so that they can actually easily get to the place they're working. So these are all very, very strategic elements, and it isn't just around social care. This is how we actually influence the local plan. It goes across the council, and it's really, I suppose, one of those areas where from a scrutiny point of view, that's where the brief actually does become a little bit wider, because I can commission a care service wherever I want to a certain degree, but I've got to get the staff to be able to work there, and part of that is around the pathway for recruitment training, but it's also about affordable housing. And it's also about the housing for people. We've put people in homes, care homes, but what about actually maintaining or actually improving people's independence by having different models where people can have their own front door if they're able, and the support wraps around them to give them that independence. So it's very much a case of how we can begin to develop models of accommodation that offer support as well. And some of that support can be through lots of different things in terms of small communities, actually how the voluntary sector integrates, live-in care, all sorts of different models that takes away some of that, shall we say, dependency situation that you sometimes get in a traditional residential model. Next slide.
Thanks, Tony. I think this is me.
It is.
Thank you. So, you heard me say a couple of slides back that in Dorset we actually have had a higher level of people requesting support than nationally or even regionally. And if you look at these right-hand boxes, these are additional people on top of that demand. So the 916 people are 798 people who came through the hospital route with packages of care. That are funded by the NHS National COVID funding, and 108 people who've come through to us who had specific issues around COVID, either themselves or carers of people with COVID, who are funded through or should be funded through the local authority funding that comes nationally. So what that means for us is that we've got an additional 916 people that we will need to assess, review, and for certain of those people plan their support packages. 222 of those people are people who would normally self-fund their care. They're getting it free at the moment, but when that comes to an end, which will be March 31st, we will need to assess to see whether they then need our support, and if they don't, we will still need to offer them advice, information and guidance so that they can make their money go further and get appropriate support. The 542 people is the number of people who were funded completely free of charge because they were coming out of hospital under that NHS COVID funding. So what does that all mean for us? So as it says in the left-hand box, we've got cases increasing again, and it's had 4 major impacts on us. One is, as Tony will know, the emergency uplift that was mandated that we give to providers to ensure the supply is still there, so particularly care homes and nursing homes. We've also had 800 new residents on short-term packages, and as I've said, 500 or so of those may require longer-term support, and they are new people that wouldn't normally cross our come through our door. We had a 4-hour discharge time in the hospitals, which meant that the approach that we have been taking and the main principles in our development of services and our transformation programme has been very difficult, because that's been a strength-based approach where everything we do should be tested with and planned with our residents and people who and families who may need to use our services, and also they should be personalised services. That's very difficult to do when you've got a 4-hour discharge time. Similarly, due to the above pressures, we've had to pause our transformation programme and our planned business as usual projects that would have delivered efficiencies in year. So we've kind of got a double whammy in terms of those impacts on us. Next slide, Sam. We have seen some positive impacts of COVID. Very much the communities coming together to support each other and all provider organisations, including our colleagues in health, working in a much more innovative and agile way at speed. That has been an incredibly positive outcome. And the work to support the shielding cohort, which has increased demands on adult social care. So 95% of those people coming through shielding were not known to us previously, but have involved work by our localities. So you can see there's building pressure upon pressure on our teams. So we've had a significant increase in demand on adult social care and housing services, particularly now we are seeing with the easing of lockdown, we're seeing significant increases in people coming forward with mental health needs and safeguarding needs, and also people requiring Mental Capacity Act assessments and deprivation of liberty. Together with carers who have done extraordinarily well throughout the lockdown, but have almost found that they simply can't cope anymore and are coming forward, and homeless people. So all in all, the people who are coming to us are greater in number, but we also have a much higher level of acuity and complexity, both physical frailty and people with mental health needs. And then, as Tony's touched on, we've got the forthcoming winter pressures, flu, Brexit, potential second and third COVID waves, not just outbreaks of COVID, which have a particular impact, but also there's been some studies to show that post-lockdown, there are levels of impact on people that take time to emerge, particularly the kind of mental health issues. And that, of course, is a national trend. And as I've said, carers requesting additional help has gone up significantly, particularly as within day services, we had to reduce what we could offer in a buildings-based support way because of having to socially distance. And that's been very positive in terms of getting people taking up much more community support. But for carers, that's been really difficult because caring for somebody in their own home doesn't give them the break that they need. Thank you, Sam. Next slide. So I'm going to hand over to Tony to talk about the programme, but just to say that we are determined to get back on track with a strength-based model, and that traditionally in Dorset, it has been, like a lot of local authorities in adult social care, a deficit approach, which relies on assessment around what's gone wrong for people and what they can't do rather than the positives and what networks they have and support, and a somewhat paternalistic approach to commissioning care, which has relied in the past heavily on residential nursing and domiciliary provision. And just before I hand over to Tony for the rest of this slide, one of the ways that we are trying to engage with people who use our services or who may need to use our services is through our transformation programme, A Better Life, and particularly through the Better Days delivery group, which looks specifically at how we can improve people's day-to-day living and getting people involved with that, together with our stakeholder advisory group, which our lead member, Councillor Laura Miller, chairs, and will have representatives from our people who use services as well as the voluntary sector. So over to you, Tony, to describe the transformation programme.
Thank you, Jill. So as per Jill's introduction, what we have actually developed is a programme which we're calling A Better Life. But what does that really mean? And I think what we've tried to actually break down is, again, taking things away from this mentality of just service and actually looking at the broader outcomes for people where they live in communities is really, really essential. So it is very much about the right accommodation being available, as I've been talking about before. It's very much around actually the right relationships as well with the workforce, really, really important, and actually seeing that as a partnership. And again, some of our language needs to change because we talk about the provider market and things like that. But in reality, care homes are actually partners and they are part of communities too. So is a home care provider, so is a supported living provider. And it's how we actually work together to achieve some of these goals. So as I say, we have got a transformation programme. It's quite a broad level of transformation, because what it is looking at is to obviously embed a strength-based approach, to look at the potential for people and how to make and maximise their potential, I suppose, to live independently. And sometimes that means not doing the standard things. Sometimes it's about actually what is the offer in terms of training, what is the offer around volunteering, rather than just actually putting somebody in a day service placement. Are there other things we could be looking at that could actually give people those real opportunities? And I think it is, again, around how do we centre around the person, around their own home and their community. So it is focusing on the individual, on their strengths. I think we learned a lot during COVID, because some of it was around, yes, we were having to do two, but there was quite often a lot of things where we would find that actually people had skills, people had resources, people had things that they could offer as well. So not just seeing the label. And we need to be able to work differently in communities to actually understand what is different in each unique community. And again, I think that's where members come in, because how we build resilience and how we build that that support really is going to be different from each area. And I think that's coming back to that point where I think we need to be working with communities and actually growing the offer sometimes. So it is about those housing options as well. It is how we get the right housing in the right place with the right support. I know we've talked earlier about obviously the challenges for hospitals and community hospitals around distance for beds and all of those sort of things. It is very much about understanding the population, understanding the communities and where we really, really focus. But underlying that, we've always got to make sure that people are safe, and obviously what we're doing is legal. It is about also recognising that we're not in this on our own. Our whole transformation programme is around partnerships. It is around the fact how we work as a whole system, and it's making sure that obviously we work with our health colleagues, with public health, with all of those stakeholders and partners to make sure we're delivering those outcomes for people. And as I've mentioned before, it's a very big focus on workforce, making sure that we've got the right skills, the right staff, and also the right, I suppose, parity in the system as well. You know, care is really important. Thank you, Sam.
Thank you, Tony. Thank you, Jill. So just before we move on to where some areas that perhaps we could suggest that we look further into, I think we just wanted to share with you, you know, this is our aim. This is where we're going to. This is what good looks like. And we've broken down there, you know, what that means for the local authority. What does that mean for members and our partners, and for the people whose lives we're all here to support? I think the conversation that we have just had and in the presentation, I hope what you have heard loudly from us is what really matters is better outcomes. I mean, I think that's come across from our health colleagues and from Teresa and ourselves, that, you know, what's most important is changing people's lives, improving the quality for people and their independence, and that, you know, the main aim, particularly in adults' world, is that we do ourselves out of a job. You know, that people don't need us, that we've got the right support in the right places, in the communities, amongst our residents, that they are able to support themselves and only come to the adult social care front door for information and for guidance and support at periods in their lives when they do need them. And our focus both is to do that early intervention and prevention work with our partnership colleagues, but also for those most complex people, those high-risk people, that we are able to absolutely provide the right care, the right quality of care in the right place for people, that those people with highly complex needs and are most vulnerable in our community, that we are getting that right for them, but allowing people still to be able to contribute in their own lives, in their own care packages. So they are sort of leading their own futures, rather than, I think, what what we have seen and what we sometimes can do is take over people's lives and tell them what is best for them. So good looks like better outcomes, people feeling in control, stronger communities, and that we are able to measure ourselves against the absolute best, and that we've got really good data and insight, so we're able to keep on improving. So finally, I would just want to mention a few areas. So next slide, please, Sam. So we've talked about, and so have our health colleagues, about the health and the hospital discharge and the impact of that. I think that is something that you will all be wanting to come back to. You know, we really need to review what we are doing underneath this piece of legislation. Are we meeting people's outcomes? Are people being supported in their own homes in the best way possible? Are we getting good outcomes for people? I think we'd want to be looking further of that. Have we got the right reablement and rehabilitation in the right places for the people of Dorset? Another area of focus that builds on that is, you know, when people have highly complex needs that are coming out of hospital or trying to live well at home, have we got that? Have we got the right care in the right place for people, and that joint approach with our health colleagues in terms of the right clinical care, the right management, and you know, that is being managed under the right pieces of legislation, so we've got good oversight and governance on that. So moving on, Sam, to the next slide, please. So the other area we've touched on, but I think we would welcome more insight to share with you, is around safeguarding. Under COVID, most recently, the safeguarding partnership boards in adults have been looking at, you'll be aware of serious case reviews, and we have recently moved to rapid reviews. So what can we learn rapidly as a system to understand where we can learn from experiences, that we do that in a timely way. So I think that would be something that as a committee, it would be useful, because that brings in the whole partnership for us to further look into. And we've touched on this a lot during the morning around the testing and the capacity and the impact on the workforce across the ICS, of which we are very much part. So that is something that we are keeping under review, and I'm sure Scrutiny would welcome looking into. Sam, I think that's the end of our slides. So thank you. I hope that was useful, and it shows the journey of adult social care, but also how do we work well together across the system. So if there are any questions, then myself and my team would really welcome having those. So thank you, Chair.
Okay, thank you very much, Vivian. I've got one question at the moment from Councillor Rennie. If I can bring Councillor Rennie in.
It's not actually. It's not a question about this. It's a comment about the meeting, Jill. It's not a question on this.
Okay. Where do you want it to come? Where would you like your question?
When we finish with questions with Vivian.
Okay, thank you. Okay,
I don't see any questions there.
Okay, I've got no other questions coming in. Your suggestions for scrutiny are really good, and I'll add them onto the forward plan for consideration by committee. We're coming up to, if I can just say, we're coming up to the 3-hour limit, and we are going to need to extend this meeting if we want to finish it or to agree to reconvene. I would suggest at the moment that we extend this meeting till 1:30 maximum, with an aim to finish in by 1:15. If members are all in favour of that, would you let me know, please? And I don't quite know how to do this.
If I could suggest, Chairman, just ask for those who aren't happy with it.
Yeah, I think that's right. If anybody is not happy, could you please either indicate or put in the chat bar? Okay.
This, Jill, was where my RTS was coming from this.
Okay, thank you very much. Right, so we'll extend the meeting until 1:30 maximum and aim for 1:15. If we can go through...
Molly still wants to speak.
Could I speak?
Yes, please do.
Yeah. We have, this morning, we've had exactly what we asked for, which was presentations, and we now understand maybe a bit of the breadth of the work that we're going to have to undertake. And the rest of our meeting we've got here about how we want to move forward. My thought, maybe we have just had to take in so much in the past 3 hours, we cannot make any decisions around how we're going, where we're going to go with our forward plan till we've had time to think about it and discuss it as a group, but not when we're looking at the clock if people have got afternoon meetings, not when we're looking at the clock if people are passing out because they need a cup of tea. I was going to suggest that maybe we have the reports all back to us again, that we will be able to see all of the presentations and inwardly digest them and have a conversation with just us members together in maybe 10 days, a couple of weeks, to look at our forward plan and then take that to Cabinet at that point. I don't know if that was other people.
I think that is a really good suggestion. What I was going to do was to suggest to committee that our forward plan is looked at a separate meeting, because I think we've just got far too much on it. And I think after having been going for 3 hours, I think we all do need a break and we need a bit of time before we do the forward plan. So if I can suggest when we do come to that item that we just defer it and ask officers to set up an informal meeting on that. If I could just take that as a suggestion at the moment, and I'm sorry to jump around the agenda, I know it is quite frustrating for officers, but if officers would be happy if we can take the agenda item on the forward plans now, which is item 8, and if we can agree as a committee that we would like a future meeting, probably in a couple of weeks' time, to have an informal meeting to discuss our forward plans. Can somebody advise me on that, please? Councillor Rennie, did you want to come back?
I was proposing that, so if somebody seconded it, it might...
Second that.
Okay. If anybody doesn't want to do that, could you please indicate now?
I did have an RTS on this, Chairman, but it seems it's gone by the by, so I'll withdraw that RTS.
Okay, I do apologise, Councillor Pipe, I'd missed that one. Thank you.
It's very much along the lines of what you've already said. I was going to suggest that you and the Vice Chairman go through this and pick out what you think, what you believe would be the best things to scrutinise, and then put those ideas to a later meeting, rather than everybody have a dogfight over their special case or their this, that and the other. I think it's, if you could narrow it down to a few very good serious bits of scrutiny, then I would suggest you take those to the meeting.
Okay, yeah, so I'll work with Councillor Rennie and we'll bring this to the informal meeting, which will probably be in a couple of weeks' time. Thank you. We've only got a couple of things to go on. I haven't approved the minutes of the previous meetings, which were on our agenda for noting. As they're only for noting, I'm going to assume... Sorry, I've got...
Beryl's say she doesn't agree.
Would you like to speak, Councillor Azard?
Yes, I don't really agree that it should be left to you two to discuss, because as Molly said, we all had this wonderful presentation this morning, and we're all present, and I think that we're all sensible that we can come to some conclusion, and we all have skills that we can bring forward to actually suggest. And is then a consensus of opinion on particular items, and I know a lot of them are important, but being that we're from right across Dorset, then we can actually put forward and then have a choice from that, because obviously this is a plan going forward for the whole year, and I do think that we all need an input to that, because as yet it's been difficult to do that today. We've been listening very carefully to what's been said, and obviously the presentations will be sent out to us. We haven't had chance to read, mark and inwardly digest, as our teachers used to tell us, so I think that I think that would be a good thing to do. Thank you.
I would say, if I can just bring you in a moment, Councillor Pipe, I would say that what I was proposing was that Councillor Rennie and myself just look at it and do a preliminary sift. We're not saying that we're going to cut anything out at the moment. Yeah. So we'll come back to an informal meeting with recommendations, but it's not it's certainly not exclusive. If I can bring you back in, Councillor Pipe.
Yeah, I wasn't suggesting at all that you have a definitive list of what's what. I was suggesting you brought back what you thought was better, what you think is good, and take it from there with other members putting in at the meeting. I've got to go because the postman's knocking at the door.
Okay, thank you very much, Councillor Pipe.
And that was exactly what I was suggesting.
Okay, thank you very much. If I can go on to the minutes of the previous meetings, as I said, we've had them sent to us for noting. I'm not sure whether I can sign them off as chair of this meeting or what the process is, but they are just for noting, therefore I'm assuming that nobody will be commenting on them.
Chairman, it's Helen. They were purely there for members' information so that they could have a look and see what the previous committees had been dealing with. Okay. They're not for you to sign off or anything like that. Okay,
thank you very much, Helen. If I can go to item 7, which is the liaison members. There's also always traditionally been from this committee a number of liaison members who attend various meetings on behalf of the council. Now we've got, first of all, we need to agree whether we want to carry on this practice of having liaison members. I would say that we do. So if anybody has got an alternative proposal or doesn't want it, then okay. I've got people coming in wanting to speak at the moment. Can I ask Councillor Rennie?
Yeah, my question was, again, we're very new, this is a new committee. I wonder if somebody could write a very short précis on which of what they actually do, these organisations, what's required. They're sent out to members, and then members let you know as chairman if they've got any interest in doing it.
Okay, yeah, I quite agree with that. That would be useful. Councillor Ireland.
Thank you, Chairman. Well, to answer Molly, I've been the liaison for Dorset Healthcare since I was on the Health Scrutiny at Dorset County Council from 2017. So essentially what I do, and I have been doing, is attend the board meetings and then reporting back to either the chairman or the committee on items I thought were of interest or that we should look at. So I think they should exist, and I'm quite happy to continue doing that role.
Councillor Pipe.
Thanks, Chairman. I too, like Councillor Ireland, have held a number of liaison roles, and there are most of those were in the role of chairman of the Health Scrutiny Committee when I was chair for a couple of years. They're very important roles, and I would urge members to get involved with the liaison roles, of which you probably have a list there, and to take full part. They are very valuable, very informative, and you're not treated like a leper.
Okay,
This is why I suggested we actually asked what the role is, and then members can look at what they would be or have an interest in and be able to attend.
Yeah, there may be members, Molly, who like Councillor Ireland, who's been in his liaison role for 3 or 4 years, who might like to continue that.
Yeah, I understand.
And people like myself who done it from the chair under the last regime of the previous chairman. I find myself without a role, but you know, I'm up for taking a role, and I urge other members to do likewise.
Okay, can I just ask? I mean, I would like more information of these, and I think an information sheet on them would be really useful. But in the interim, because I am minded that we haven't got another meeting until November, and there are probably meetings that people would like to go to. Are there anybody who would like to fill these roles in the interim? I've already had Councillor Ireland. I think.
Councillor Pipe.
Sorry?
I would like a role.
Which one would you like?
I don't know what you've got.
Right. I've got CCG, Dorset CCG, Dorset Hospital NHS Foundation Trust, Dorset Healthcare University NHS Trust Foundation Trust, and the Southwest Ambulance Service NHS Foundation Trust.
Which is the pool-based one, which is easier for me. Should I have to?
I don't know. This is the problem. I've got no more.
Nick, can I ask Nick? Nick, are you there?
Yeah, I am. So I do healthcare. So I'm the Dorset Healthcare University Trust one. So that's the one I've been doing for the last 3 years.
Okay, where's that based?
Central House.
Okay, cool. So cross that one off, and I'll take any of the others. Just tell me which one.
Okay, if I take the CCG.
Yeah.
So we've then got the NHS, the Dorset County Hospital NHS Foundation, and the Southwest Ambulance Service NHS Foundation Trust. I don't know where they're based, but if you'd like to choose between those two, please.
The ambulance one is based in Exeter, so I really don't fancy that one. Beryl likes that one.
Hang on, can I just say they have got a depot. The ambulance one has got a depot in Lubbock Way in Dorchester, and yes, I did have. So I think that's where I met up with some of the directors there. They don't actually invite you to their meetings. They actually will. You can arrange a 6-monthly visit and speak to certain directors that you'd like to speak to. So it's not as if you attend a meeting. This is where it needs a little bit more information about actually how you liaise with them, because it's not always attending meetings. Okay.
Right. I'm going to pull this at the moment, and we'll take it to the informal meeting when we've got some more information. I'm assuming that we don't need a committee decision for who attends which. If I'm right in that, is that all right, Helen?
Yes, that's fine, Chairman.
Okay, right. So I've just pulled this item, and we're going to take that onto the informal meeting. Right, we've dealt with the forward plans. I understand we have no public participation. We've dealt with the urgent items, and we have no exempt business. So I think on that we've finished the meeting.
I'll stay a minute, Jo.
Okay. Thank you very much, everybody, for having attended. Hang
on. Is you not saw Tim Goodson's RTS on there?
Oh, sorry. Sorry, Mr. Goodson, would you like to come back in? I hadn't noticed your RTS.
It was just picking up on Councillor Pipe's point there on the liaison officers. I'm a bit surprised that not got effectively what would be the new merged University Hospitals Dorset on there, so effectively Bournemouth and Poole one. At least a third of the patients that go there actually come from Dorset Council's area. So and obviously that is based in Poole and Bournemouth, but I think you should have a link with them as well. I wouldn't just say that should be BCP, because it's a pan Dorset service that. So I just thought I'd add that.
Okay, thank you.
I would very much like to be considered for that, Chairman.
Okay. Sorry, Molly?
Sorry, yes. I'm sorry, I didn't do ask this. Do you know, I think we may even find that Vivian and Teresa have got things that they want to have a liaison for. And I think maybe, Jill, it's a conversation to be had and look at a proper definitive list.
Yes, I will do. Okay, I'll put that on my agenda to do, and we'll bring it forward to the informal meeting. Right, thank you very much, everybody. I'm going to call the meeting to a halt now at, 7 minutes past 1. And I'd like to thank everybody for bearing with us this morning. It's been a very long meeting, and I must admit, my stomach is now rumbling. So thank you very much, everybody.
Well done.